Assalamu alaikum. Good morning and welcome to the third Surgical Annual Research Day, or as we like to call it, SARD. SARD in Arabic means to narrate, and it perfectly captures the essence of our gathering here today. My name is Dr. Akshay Bangera, and thank you all for being here. To kick off the day, please welcome our Chair of Surgery and Senior Attending Surgeon, Dr. Mansour Ali, for the opening remarks.
Assalamu alaikum. Good morning, esteemed colleagues. Welcome to the third Surgical Annual Research Day, where the art of surgery meets the age of automation. I am Dr. Mansour Ali, your virtual host today, a testament to the very advancements we'll be exploring. Our mission remains steadfast: help deliver best care for children. And that cannot be done without your tireless dedication to seeking and implementing latest evidence. Your orisons here today is a testament to that. Today, we will look at possible solutions for the most common issue in surgery: lack of manpower. Automation can be reliably done in research and for quality monitoring using multiple tools. Today, we will delve in automation surgical registry, monitoring quality metrics, explore groundbreaking AI tools, debate the ethical considerations of AI in a human-centered research, and foster collaborations that will accelerate surgical innovation. So, let's engage and ask the challenging questions and look at how we can best invest the available advancements. Dr. Noora will provide an overview of the agenda and what to expect next. Shukran jazilan.
Assalamu alaikum. Good morning again. This is the automatic part of me, so you have the manual version now. So I would like to welcome everybody. Our CEO, Dr. Iyabo, kindly came. I know she's very busy, so we will give her in a minute time to say a few words. Automation is a big thing in the healthcare, and I think we're trying to be part of that and use the automation as much as we can. Recently, in American Journal of Surgery, they even used AI integrated in robotic to write up surgical or operative report, which was extremely detailed, even better than the operative report the surgeon writes. So, we are there and we try to be up to date. And Dr. Iyabo, please, would like you to say a few words.
Good morning, everybody. That AI thing was a little eerie, seeing Dr. Mansour like that. But, it's really a testament to the advancements in technology, healthcare, and in the intersection between biotech, life sciences, medicine, research, technology. Glad to be making a few words this morning, and I'm really, really always impressed by activities like this, because it really reinforces and reemphasizes that this is an institution that is going to do groundbreaking things and continues to do groundbreaking things. There's no advancement, there are no cures, there are no intervention without research and development. The pace of research and development at Sidra Medicine is picking up. Your chiefs, yourselves, the board, and the external environment, namely the regulators, the ministries, are beginning to recognize how critical research is, and are beginning to, more importantly, they're beginning to recognize the role that Sidra plays in the management of children, especially with genetic and rare diseases. Sidra is becoming a hotbed from the perspective of pharma, from the perspective of academic medical centers globally. The pace of inquiries we're getting to collaborate are increasing. From my perspective, it's about understanding what the needs are within our organization so that we are well positioned to continue to leverage the good work you do. It's events like this, again, that reinforces the idea that I need to be speaking with the ministers as often as possible. And that is what I've been doing over the last month, speaking with Her Highness, speaking with the ministers, that we need more regulatory ease, we need more protections for our physicians from a professional liability standpoint, just by virtue of the fact that we take care of some of the sickest children, and that we need more funding, right, so that we can have protected time for our researchers, not just our physician researchers, but our nurse researchers, building out an infrastructure for nursing research as well. So we have a lot of work to do. Rest assured, we're doing quite a bit behind the scenes. We want to increase strategic collaboration so that we can continue to upskill within, upskill our staff, our physicians, our nurses, our allied health professionals, and increase capabilities from within, as opposed to continue to rely on a revolving door of people coming in and leaving. So from my perspective, investment in research is a priority. Investment in professional development of our people is also a priority. Investment in education is a priority. And then, of course, investment in research and delivery and development. So I want to thank you, Dr. Mansour, Dr. Noora, and all the members of the surgical department, and for your engagement, for your participation, because it's things like this that gets us to where we want to as an organization. So the best of luck today. I would have stayed, but we have a crisis that I have to deal with, and enjoy your day. Thank you so much.
Assalamu alaikum. Good morning, everyone. Happy to have you all here, of course, in person and virtual attendees. We would like to introduce what we're having in our busy and exciting day today, inshallah. This year, as you saw, we are focusing on a different angle. We have it theme-based. We're focused on automation and how we can employ it in clinical research. I'm going to take you through the agenda for this morning. We're going to start by a talk on how automation can be employed in facilitating data collection for registries. We're always struggling with manpower, so that's a very strong angle. We're going to use short bowel registry as an example. Following that, we're going to hear from the contestants for the research category. 5 talks, we'll be judging them, and then we'll decide on the winner. After a very short coffee break, we're going to tackle how automation can be used to monitor KPIs. We're going to use the trauma dashboard as an example. This will be followed again by a panel discussion. Then the contestants from the quality category will present their talks, 5 of them, and again, we'll decide the winner. During the lunch break, I would love for you to explore what we have outside today. On the side rooms outside, we have 2 interactive sessions, one of them led by Maria. It's chat with the bot. So we'll explore how you can look at some of the open access AIs that we have and ask them targeted questions to help facilitate your research at every stage. And then next to her will be Dr. Hassan Qurban from HBKU, showcasing his AI model in predicting verbal language from IQs. He's awaiting patent. It's a very exciting project as well. Following our lunch break, we'll be shifting gears to AI. We'll look at how AI can be used for certain steps in systematic reviews, and this will be followed by a panel discussion. Our last session will be on ethics in AI and how they can be monitored locally here at Sidra, what rules govern AI. And of course, we will end with our award winners. This year, we named our award after the late Dr. Michael Livingston, our pediatric anesthetist, the father of anesthesia, who passed away a few months ago. His wife will be attending as well, inshallah. A few changes and updates for this year. We have partnered with Qatar Medical Journal, who will be joining us outside in a booth. I encourage you guys to interact with them and see what do they have to offer. We hope that our work here in SARD this year and going forward will be published on the Qatar Medical Journal on a special issue. We also have our sponsors desk, MedTech, outside for you to chat with also and find out what updates they have to offer. A few housekeeping points. The QR code for the agenda is at the back of your badges. It's also outside next to the registration desk. If you are unfamiliar with the area or you need assistance with anything, please approach anyone with the red lanyard. And after the event is done, we look forward to your feedback through the survey. This is very important for us to improve on next year. Also, check out our webpage. We will be updating the sessions and uploading this recorded session for access later. Past sessions, PDFs, if accessible, will be available also on the webpage. Thank you. With that, I'd like to introduce our next speaker, Dr. Saleem. So Dr. Saleem will talk to us about automation at the level of data collection. He's a general surgery attending who's worked closely with short bowel patients and worked on collecting their data. However, we're now shifting gears to automating that data collection. Dr. Saleem.
Good morning, everybody. Assalamu alaikum. We talk about automating data collection this morning. It's been an exciting journey for us the whole of last year. We've been working on it a lot, trying to do this, and we are midway. We've not reached our full space yet. I have no financial or any relevant or commercial interest in this. It's purely for patient care and patient. Yes. So what is short bowel? Short bowel is a disease where patients have lost their bowel due to any reason. Most of it is surgical excisions due to neck, due to volvulus, due to gastroschisis. Crohn's disease, we don't see that so often. Congenital atresia, etc. Leads to dependence on TPN and need for specialized nutritional care. Why does it require? It's a lifelong disease. These children stay with us till they are 18 years of age. We follow them up regularly in our multidisciplinary clinics. It has huge implications on complications such as liver disease, infections, nutritional deficiencies, etc. And definitely it's a disease which requires multidisciplinary care. We are still integrating many parts and pieces of it together, and it's really exciting. This is what we call our program. It's called the BEAR program, Bowel Expansion and Autologous Rehabilitation. The focus being on medical management, surgical interventions that we do, nutritional strategies are so important, and patient and family support are really essential because the mothers and the parents go through a lot of difficulties with this disease. So with that brief outline, let's get to where we want to do today, or what we want to talk about today. Why is this data collection so essential? We've taken short bowel syndrome as an example because it has long-term outcomes, long-term problems, and these children, like I said, require long-term help and care. Therefore, tracking the disease progression and treatment outcomes becomes very difficult. Also, as a disease, there is no one solution for everything in this disease. One patient responds to something, the other patient does not. So it requires personalized therapies for better rehabilitation, and also requires and there is a need for research. It's a new field. It's not very many centers are doing it. We're the only one in the Middle East doing this work. So there is need for research, need for development of centers. Also, predictive models can be created as to which patient will develop these complications, which patient will get off TPN sooner, all that. Also, there is a need to strengthen global research on this disease. Now, this is the process that we've gone through so far. We first defined a purpose, defined that we want to create this registry. We got a multidisciplinary team in place, clinicians, IT support, CERNA support, all that. And then we've been constantly talking to them regularly to get this process going. Then we designed the data collection. What kind of data we want to collect, demographic data, how long to connect, how often to collect. And then we decided what platform to use. So these are some of the things that I will cover during the talk. We had to identify a platform and then develop an entry method of entering this data. How do we get this from CERNA into the registry? And that's part of the automation that we've been working on, and really, really exciting stuff. Also, going forward, we need to get ethical and regulatory approvals once the registry is up and running. It's not yet running, but we're almost there. We will have to pilot it and then implement it on a fuller scale. What is REDCap? REDCap is the platform that we're using. It's a secure, web-based application for building and managing research databases. It's developed by the Vanderbilt University. It's used for clinical research, longitudinal data tracking of patients, developing patient registries, and multiple site collaborations. This is what is exciting. So we hope that in the future, we will be able to convert this into an international registry. The registries that are available for short bowel syndrome are so far mostly surgical or the STEP registries, and we hope to make this into a more comprehensive registry. What are the key features of the REDCap? It's a secure, HIPAA-compliant, web-based data entry platform. You have customizable forms and surveys. This is really, really useful for us. Automated data validation makes sure that the data is correct and accurate at the entry point itself. It has multiple role-based or multiple users, and you can define the roles of each user and specify what permissions are required. That again helps data security. It's also available in an offline format where collection can be done on mobiles, and even if internet is not available, it can be utilized. It also tracks every changes that are made. There is an audit that is created, and that again helps data security and making sure that things are happening in a proper way. The security compliance, it is HIPAA compliant. The European version of it, the GDPR compliant, and other security features are already compliant. The interface is really, really friendly. No programming skills are required, and it can be customized to whatever needs or whatever is required by the research that is to be done. It's free for non-profit organizations. Sidra is subscribed to it. It connects to the CERNA, and that is what is really, really useful, and that's how it helps in automation. It's also useful for small studies and maybe even bigger studies as well. These are some of the other data collection platforms that are available. They have specific requirements and specific are used for specific things. So how do we choose a right platform? Data security requirements are very, very important. It has to have ease of use, and the learning curve has to be short and easy to understand and implement. Cost and licensing are important. Integration with existing systems like the CERNA in our case, and scalability for future projects. Now, for short bowel, there's so many people involved. It's so interesting when you sit in these clinics, the multidisciplinary clinics. Each one is looking at it from a different perspective and creating the best for the patient. Now, How is it that we are creating these registries? We're looking at a global perspective, a multi-center design, and we hope to include patients with we hope to include all patients of all age groups. We hope to include, these are the data that we are collecting, demographics, treatments, and outcomes. Patient demographics, age, sex, etc. Surgical history and anatomy, nutritional data, whether these children are on parenteral nutrition or enteral nutrition, medications such as GLP-2 analogs, etc., complications such as IFALD, CVC, thrombus, and CLABSI, functional status and overall outcomes are we are looking at. Now, how does automation happen, or how does REDCap help automation? It's a web-based data entry. It can be accessible from anywhere. Real-time data collection is possible, captures that, thereby preventing errors, etc. Automated follow-up and reminders are possible. Data validation and quality checks are also possible. Role-based access control assigns user permissions. Customizable reports and dashboards are possible. Integration with other systems and mobile data collection. Benefits of automation: improve data accuracy and completeness, reduce workload for the clinical staff, which is important for us. There is also enhanced accessibility for research and facilitation of multi-center collaboration. These are the security features we talked about already. Now, how does it facilitate research queries? The data is structured and collection is very organized. Advanced filtering and receive patient cohorts and automated reports are possible. It enables real-time data collection and predictive analytics are also possible. And this is something that we're looking at, international collaborations, and this REDCap really helps us do that. We are also able to integrate with other registries, and global sharing of data is really useful. And this is where we are looking at going forward. We're looking at biomarkers, gut microbe tracking, etc. And we're also looking at symptom tracking for these children. So this is where we want to get in the future, and I think this conference is all about that. So this is our interesting journey so far. We've reached somewhere in the middle of where we want to reach. Thank you.
So thanks, Dr. Saleem. That was interesting. We have started something new in Sidra here, the registry. We'd like to open for questions regarding Dr. Saleem's talk and any questions to the IT team in regard to this matter.
So thank you very much, Dr. Saleem. It's a very amazing project and very inspiring. It's not only for standardization of the data, but also for more real-time entry in the time frame, particularly in surgical procedures where it's sometimes very subjective, and when you put it very soon to the surgical procedure or acute to the patient presentation, it can be more value than even the structured prospective studies. So my question is that how did you design the entry points? Is it based on what you believe is most important, or based on the data points variables for large studies, so that it is validated, so that you don't need to come back every now and then and you add variables?
Yes.
So that's my question.
Yes. So what we've done is over the last year, we've actually sat down and designed forms. So on Cerner, there's something called Power Forms available. So we've designed those forms, identified the data that we need to collect, and designed those forms. And once we implement, I'm sure there'll be a lot of problems as we go forward, but the forms are designed in such a way that it collects all the data that we require. And once the forms are filled, we are going to have that automated onto the REDCap, directly onto the REDCap. So the entry points become less. Of course, we are having issues with it, which we are sorting out with the Cerner team, but we're getting there.
So the blood variables and like...
those will be automatically
Okay.
taken. The clinical points we will have to enter, but the lab results and the investigations will go automatically, yes.
Thank you, Dr. Saleem. Second question, please.
That's very practical. Very practical question.
Yes.
One of the main problems that can happen, and this is for you and for the IT team, one of
Yes.
the problems happens when you start the research, collecting data, is that you may discover later on that you need other data, okay?
Yes.
So how
Yes.
difficult, from practical point of view, is to modify this, or is it written in the stone and you cannot come back on a power form? I'm asking because we are starting the same with the spina bifida.
Yes.
If anybody from IT want to explain that?
So the question, the practical question is, how difficult is to modify a power form after you started the collection of the data?
After submitting.
So you say after 3 months,
Yeah.
you say, oh, I missed this data. Can I modify the power form? How difficult or not difficult is it to do it?
Okay. So I'm from, this is Vinod. I'm from Cerner team. So we customize and like,
Hold that closer, yeah.
sorry, now? Okay, so we build power forms, which is like, I'm working on power form. And this is my colleague, Kiran, who work on data collection, like from Cerner. He pulls the data and give it in a structured format to send it to the REDCap or this system. So from my point of view, this modification, like it's a real time, actually should be, like they can correct if I'm wrong on that part. So the what current documentation was, I think they were doing with physician documentation, like in PhysDoc, which actually goes as like readable, but to pick the elements, like what they want, the data points, it's difficult. So that's why we are actually moving all of them into each required data into a capturable data, like DTAs, right? So we connect that with the integration. So modification, once they do modification, the data should flow. The data should flow to the system. Yeah, it's editable. Yeah, it's possible. Yeah.
Yeah, if you allow me here. So the data it will be refreshed, but mainly we will push the data from Cerner to the REDCap in a timely manner or a real-time manner. Mainly for the new records, but also if there's a new updated records or updated information, also it can be pushed and update the REDCap for that. But yeah, it's possible, yeah.
So I have a question that maybe other people will start thinking about it later. Dr. Saleem, some of our documentation that is a requirement by JCI that has to happen is not very useful for us for the registry. So how are you dealing with this situation?
Yeah, so that's a difficult thing to sort out. We are trying to do it the way that JCI requires it. We cannot not have that. We're trying to build the platforms in that format. And of course, there are limitations. That's the challenges that we've had going forward. This is a work in progress. Yeah, we almost got to a point where we have to do double entries, which is not ideal, which is not perfect, which is not what we we set out to achieve. But at the moment, that seems to be the only way forward. That's a really difficult one to crack. And we've still not figured a way out of that.
Oh, it is working. Can I?
No.
Yeah.
So I have another practical question. So like about 15 years ago in the US, we were using REDCap for our research, and it was great. And then here, we decided to do a similar thing for our cleft and craniofacial program. So we built all the terms that we wanted to collect, all the points, data points, and then came to the same fork in the road. We had to use power forms. So we met with IT to start to build the power forms. The practical problem for us, though, is we don't have the manpower to be doing our dynamic documentation and entering into power forms. There's just not enough time to do both. And I was hoping that we could, substitute the dynamic docs and just do our documentation solely in power forms. But it's not, apparently that's not workable because it's not the data's not searchable from power forms. The hospital wants us to use dynamic docs for our documentation. So we're faced with the situation where we have to do double entry of information. We have to use the dynamic doc to put our assessment and plan and narrative about the patient, and then we have to go to power form. So I don't know if there is a solution where we could just do a single note that would be useful for uploading to REDCap. It would be useful for uploading for, coding and auditing of documentation. It could have our assessment and plan all in one place. Otherwise, we need more manpower, which large research organizations have the kind of staff to do that. We don't have that here. So I'm not sure if you guys have any sort of thoughts how we can have a one place that works for REDCap, works for everything else.
Yeah. The power forms, actually, we can configure them to post the updated version of the power form into the documentation, dynamic documentation with the textual rendition. We are currently, the requirement is to do that. Like all the power forms, what they've submitted, we are going to actually post them into the dynamic doc, in the documentation section. So everything will actually come there in the documentation. So you don't need to redo it again. If there is a requirement from coding perspective, there is a dynamic doc from your department, you need to fill it. We can actually look for any sections within that which from our power form, we can pull that data into your documentation. But all the power forms, what we have created, which post the documented version into the dynamic, the document section in PowerChart.
Yeah, Dr. Noora again.
Another question. It will be important for the audience also to understand if there are limitations to power forms in terms of types of data that can be captured, and what would be those limitations. An example would be like a picture. Is that something that you can do or not?
The limitations are like, as you said, pictures. You can't actually capture picture and attach to it as of now with what we have designed. Otherwise, all text, numeric, all those things, everything, whatever has been submitted, we don't find any challenges technically to fulfill those requirements. We have done it. If there is something auto calculations of multiple choices, then that would be kind of technical limitations are there. If multi-choices are there, if you want to post some results, because PowerForm has got like some limitations, predefined formulas, which will work. But based on what is the requirement, we can tell whether it is not possible or possible. But whatever we have received so far, I think 8 or 10, nearly 8 PowerForms requirement, I think which is achievable. There is no challenges in it.
Also, in the dynamic documentation, whatever you enter into the power forms, we can create a auto text, and with one auto text, with one auto text, you can pull all the data into the dynamic documentation. If in the cases, for example, what you asked, if there is some data, IT side, yeah. So if there is a combination of data which you wanted in dynamic documentation, so some data you want in dynamic documentation and some data you want automatically pull from the power form to dynamic documentation. With one stroke, you can pull it from the power forms. So there is a concept called as auto text. So if you create auto text, So you can just with one click, you can pull data. Now, only in the case if, yeah. If only in the cases if you want information, if you want information from both power forms as well as dynamic documentation, you want to do something, you can use this method. Otherwise, as Vinod explained, any document, if you want complete information from power forms, basically it will post as a document. So you don't need to do any second step. Yes, yes. There is a concept called
So you asked the question, the power form, is it accepted by JCI? They don't look at the format of the document, they look at the content. So for example, you have to mention allergies, even if for your registry, it's not important. It's important for JCI. This is if you're looking for single documentation. We have hit a wall with the short bowel, so we're thinking it's almost time to say, let's do a regular documentation and let's duplicate for the sake of the registry, because we want the registry much more than we're struggling. We're going to put the registry automated like labs and whatnot. It will go automatically to RedCap without any input from us. But things that subjective from Dr. Saleem's input from clinic, for example, or bowel length from operative findings, those will have to be manually entered into a neat, structured, to the point power form.
But you know how our dynamic doc pulls in all the past surgeries, it pulls in social, it pulls in everything. The power forms won't pull all that in. So if we switch this to power forms, unless you have some new information, but when I worked with Maria and I worked with IT about 3 months ago, we came to an end of the road where it seemed like the power form just wasn't going to be able to have all the applicability to show the medications, show the orders, all the things that pop into the dynamic doc you don't have in power form. And so we were going to have to do double entry. So we should probably talk offline. If there's a way of getting around that, we would be delighted.
In Power Form, we have an option. We can design to pull the previous latest data into the Power Form. As and when you open the Power Form, they don't need to enter everything. If it is a previous documentation done on that particular question or response is already saved, we can design like that. But within dynamic doc as well, like what Kiran explained about auto text, with which we can actually pull all the data from the Power Form. Also, the dynamic documentation currently are using, if there is a section inside that, if you want some data to be pulled in from the Power Form, we can work on that. We can do that.
Any more questions from this side? Okay. Does that answer the question, Mitch, or?
Yeah, we can.
I understand there is a lot of going back and forth about this. We are not used to this, so this is something starting here. I think this was a good opportunity for people to understand there is something going on about how to collect data and power forms and so on. Do you want to add something you wanted to add?
Nothing. Currently it is in the build stage. We will build and see what's the feedback from the end users. Based on that, we can configure, we can update our, there are different components are there within Power Form. So it's possible we can work with them, because the one which we submitted already, which is fine with them. So that we don't receive any feedback complaints. So there are still in progress other Power Forms. Once that is done, we can actually take the. I think. Yeah.
I saw a patient yesterday who's also followed by neurology. You know, Dr. Ruba, she's the one who really was the first one, I think, to develop a registry here at Sidra for the epilepsy program. And this patient has epilepsy, and I noticed that Ruba entered 2 notes. She entered a power form, was the registry, and then she entered a dynamic doc for her clinical, documentation. So that's a perfect case in point where she had to do double entry. Now, I don't know if she has a team that helps her with the entry of information, but most of us don't have that.
Her nurses.
Right.
Some of the documentation.
Okay, so, but I mean, if there's a way of doing it as a single note, as you say, then Ruba needs to know this too, because she's doing double.
Yeah.
Since we have still some time, one problem with the single entry from a JCR perspective is it cannot be countersigned. So if your resident or fellow or trainee fills that power form for you, there's no way for you to countersign, which means if you do a single entry, it's going to be done by an attending or an independent practitioner because it's not going to be countersigned.
One last comment, yeah?
So the question is easy. Can you auto-populate this power form from your notes? This is what everybody wants.
Yeah. So entire note we don't actually put, that's what like if there is a template what doctor which is using for this documentation, so we can actually pull those required data. We have to map that with the current section and we can build that. Yeah.
In Cerner there is a concept called smart template. We can design any data what you enter in the power form. We can create a smart template and we can design how we wanted that information need to be placed in the dynamic documentation. That we can do without any manual additional step.
So the thing is that, you know, I like your technical explanation. We are trying to be as simple as possible. When I write a note for a short bowel patient, yeah, this patient is supposed to have a power form as well, yeah? So when I write my note, the information that the power form requires for this, for data collection will be extracted from my notes and populated automatically into the form.
Yes, I understand your question. Yes, it is possible.
Is it possible or not?
It is possible and it is implemented in some areas also. We have developed smart templates and we have configured it inside the dynamic documentation where without any manual step, the moment you open the dynamic documentation, for that encounter, if there is a documentation of power form, it will automatically pull inside the notes and you don't need to do any additional step.
You are saying that from the power form goes to the dynamic.
Yes, yes.
And he's asking the opposite.
Opposite, no. Opposite, no.
That is what we want.
No, vice versa, it won't happen. We are talking about anything documented in the power form, it will come to the dynamic documentation. Yeah, opposite, no.
The other way you cannot do it?
No.
You sure? There's always two ways.
I think
a single direction.
We'll just have one more comment.
What I'm hearing is that there are multiple people trying to do this, and we're reaching that same point where we're getting stuck. So I think we should sit together. Maybe Maria can organize that, and sit with the Cerner and the IT team and take that forward. I think it'll be worth having that discussion.
I'm sorry, I'm just very straight.
Yeah.
IT, please, the world cannot fit into your world, okay? The real world is here, okay? We need you to come to us, not the opposite, okay?
So I think that's, this discussion will be heated up a bit more. I think we'll stop it here. Thank you, Dr. Saleem.
Yeah.
Thank you, the panel. I think there's a lot of questions about this. This is new to everyone here. And I think we'll have more challenges in the coming months, not years, I say. Thank you, Dr. Saleem. Thank you, the panel. I think because of the sake of the time, we will be jumping to the next session. Thank you, everybody. And
thank you.
Thank you to the panel and to Dr. Saleem for that insightful discussion. Now we move on to one of the highlights of our day, which is the research presentations. We have received numerous impressive submissions over the past few weeks, and to introduce the criteria for judging, the judges and the panelists themselves, I would like to welcome our moderator, attending surgeon of urology, Dr. Tariq Abbas.
Good morning, everyone. Thank you very much for allowing me to participate in this very motivating event. Thank you very much, Dr. Mansour, for the valuable help every time we face any difficulties in clinical and research, of course. And I would like to welcome two esteemed judges in this panel. Dr. Amr Sayed, he is a distinguished pediatric surgeon from HMC. He's on the way, he will reach soon. He has always the interest in research. He got a master in public health from Qatar University. And Dr. Luis Saraiva, he's an accomplished researcher leading the Human Disease Modeling Therapeutic Laboratory and the Congenital Malformation Clinical Research Program. The Congenital Malformation Research Program is a very interesting pillar in translational researches of Sidra Medicine, and it contains mostly surgical pathologies like spina bifida, urology, kidney malformations, cleft lip and palate. So he is very melted with the surgical pathologies and oriented to surgical clinical research. I would like to remind the presenters that the total time for each one is 12 minutes, 8 minutes for presentation and 4 minutes for discussion. There will be a timekeeper to allow a smooth transition between the sessions, and good luck everyone. Thank you.
Good morning, everyone. Assalamu alaikum. So I'll be presenting cast wedging in pediatric forearm fractures. Is it effective? A retrospective review of patients from a tertiary referral hospital. So I have nothing to disclose. So forearm fractures in pediatric patients are quite common, and mostly they're managed by non-operative methods. However, recently there has been a growing trend towards operative management of these patients. We retrospectively reviewed the data of our patients who underwent cast wedging from our clinic. Because it's a general assembly, we have general surgeons and all other people, I need to say some words and terminologies we use. There is something called coronal angulation. So if we have a forearm fracture, there is an angulation in AP plane, we call it coronal angulation. Similarly, in a lateral view, we call it sagittal angulation. And something is called a bayonet apposition when there is an overlap. There are indications of intervention whenever there is a displacement of fracture, when should we intervene? So there are multiple criteria. This is one of the old papers, people accepted this one. But then there are these 14 studies. They produced other data like based on age, based on sex, based on the degree of angulation. All of this is about when to intervene. But this is what we have in the end. So this is from 2023, up to 10 years of age, more than 15 degrees in sagittal plane, more than 10 degrees in coronal plane, and bayonet displacement of more than 1 centimeter, go and intervene. And if the patient is more than 10 years of age, more than 10 degrees in sagittal plane, more than 10 degrees in coronal plane, and more than 1 centimeter translation, go and intervene. Why should we intervene if we have already reduced a fracture in emergency? That's what we usually do. We do it because there's something called loss of reduction. This is a 6-year-old boy, had a fracture, we reduced it, we were happy, but then this is what happened when we saw this patient in the follow-up. After 10 days, there's 27 degrees of angulation. Same story here, we have 7-year-old girl, a fracture, was reduced nicely in emergency, we were happy, but when we saw this patient, again, an unacceptable angulation, according to the criteria, we should intervene in these patients. So a loss of reduction has been seen in 39% of patients, and it happens usually in first 2 weeks of follow-up. And whenever we are faced in such a situation, we have few options, either to take the patient to the OR, under anesthesia, remanipulate, or operate and put metalwork in. But there is an intermediate pathway. We can do cast wedging, and it has been explained from 1936 in German literature, very commonly used in adult population, but not commonly used in pediatric population. So this is what we call cast wedging, and we do it in our clinic on OPD basis, outpatient clinic basis. These are the cast wedges which we use. This is a systemic review of patients, which they did on pediatric patients to look into how many patients had cast wedging done. And you could see only 3 studies included, so it's very less commonly used. And from 2014, this paper showed 249 patients, and the other one in 1995 had just 6 patients. So we're doing something very unique, not everybody is doing. So we retrospectively reviewed the data from our patients who had loss of reduction, which we had reduced in emergency. We did all the demographic data collection, we did pre-wedging and post-wedging angles initially, and at the final follow-up, we also did t-tests to see if they are statistically significant, and we also had complications recorded. We had 2,090 new patients who attended to our clinic from 2021 to 2024. 160 patients had cast wedging done. However, 20 patients were last follow-up, couldn't be included. Out of 142 patients, 119 were boys, 23 were girls. Average age of wedging was like 9.4 years, and most of the patients had distal radius and ulnar fracture. So the results were like pre-wedging and immediate post-wedging. Final follow-up, you will see coronal plane was 10.36 degrees, sagittal plane was 15.49 degrees, and all of them improved till final follow-up to 4.24 degrees and 8.20 degrees, respectively. If you see this pre-wedging and post-wedging angles, all of them are very, very significant. So this is how wedging works. This 12-year-old boy had good reduction, unacceptable angulation of the first follow-up. We did wedging. If you see the third row of x-rays, you will see this is how wedging looks in the x-ray, and this is final follow-up. So these are few examples, like this is 12-year-old boy, had a bad displaced fracture. We reduced it, but first follow-up, we saw this is unacceptable angulation. Immediately post-wedging and final follow-up is quite acceptable. So we had 3 patients who had inadequate or unacceptable correction after wedging. So this is what we do. We need to do something, and we surgically intervene it. One patient had median nerve palsy, and patients, whenever we do cast wedging in pediatric patients in the outpatient basis, they have short-term pain. This publication from Germany and Switzerland, they experienced that patients have minimal short-term pain, but they do get this good alignment of reduction. This is a 6-year-old boy, had wedging, but failed wedging, needed surgery. You can see the wires placed in. This another patient, 10-year-old, had plate put in when it failed wedging. As I said, 39% lose their reduction. And the reasons are there is loss of there is decrease in swelling, the cast, how the cast was applied. They are all of them are the reasons why wedging sometimes 39% fails. However, there has been a trend towards surgical intervention. Even they do not cast, they just go for surgery. Surgery has its own complications like hardware failure, migration, infection, loss of reduction, reoperation, nerve injury, and patient has to go under knife or under anesthesia. So cast wedging offers an alternative pathway to surgical fixation whenever we're faced with patient who has loss of reduction. We had some limitations. It was a radiographic analysis. We didn't follow clinical data. We don't have a long-term follow-up, and we decided on cast wedging depending on surgical preference, a surgeon's preference, and we couldn't reproduce the film-to-film, X-rays every time. So our conclusion is loss of reduction after close management is very common. We have 3 options. Go to the OR under anesthesia. There's huge use of resources, and you could indirectly revive it that we save a lot of money by doing cast wedging. If it's 162 patients, it's huge amount. Our series is one of the largest, as I said, just 3 papers, and our series like 162 patients. Based on our study, we recommend getting well accustomed to the use of, it's an art actually, art of cast wedging in pediatric forearm fractures to avoid unnecessary hassle of remanipulation and avoid surgeries actually. So I should thank Ms. Maria. She is an amazing person, and she really helped us to go into this. Also Ms. Reem, who helped with the statistics, and the IRB team. Our Mr. Mark and his team, our orthopracs, they do the perfect job whenever we told them and show them why to wedge a cast. Thank you. Thanks a lot.
Any question?
Thank you very much, Doc, for the inciting idea. I'm not an orthopedic surgeon, but what comes to mind is wanting to know, it almost seems like a very perfect solution for our kids. What are the limitations of wedging? Are there scenarios where you shouldn't go for wedging? Is it age, for example, limited? Do you need strict follow-up so for the patients who are traveling or not residents in Qatar, you fear that they will be lost to follow-up, so you avoid wedging? What are the restrictions? That's question 1. Question 2, it seems like it is cost-effective, but have you looked at the costs compared operative versus wedging in your case series?
So thank you for the question. There are the way we manage our patients, we do reduction in the emergency and we place a follow-up like within 10 days. So cast wedging can be done within 2 weeks of time, preferably around 10th day when the fracture is still uniting but it's not healed. So if the patient presents late with an angulation, so at that point in time, cast wedging has no role because it will not change the configuration of the fracture. So time is one of the limitations. So we need that's how we arrange the follow-up of our patients. We reduce them in the emergency, and we do a lot of work from emergency actually. And we see them in 10 days. At a time when we think he might need wedging, there are no age is not a criterion when not to do wedging. We have done wedging in 3-year-olds as well, up to 14-year-old patients. The other question was about the cost. So we haven't looked at the cost, but if you see, this is a clinic-based intervention where our orthopracs, they do a wonderful job. They cut the cast, correct the angulation, and we prevent the patient from going to the OR. It's a huge cost saver to the hospital. We are preventing them from an anesthesia. We're stopping them using a knife, putting wires, putting implants. And whenever you put a plate, you need another surgery for removal. A scar, a lot of complications can happen whenever you place an implant. So this is a very simple solution. We're one of the centers, we have biggest series, and we're doing it. And when I came into Sidra, it was already established practice. I had not seen this happening in my entire career,
That's really interesting work you're doing. You're doing it in the ED under ketamine sedation, is that right? Or in the clinic?
So we do reductions in the emergency. We place the cast in the emergency. We reduce the fracture under sedation, under ketamine. So then we schedule a follow-up after 10 days, around 1 week to 10 days. At that time, we repeat the X-ray. We do X-ray, and if we see if there is loss of reduction, as I said, 39% patients can have loss of reduction. At that point in time, we decide according to the criterion whether we need to wedge a cast or not to wedge a cast. We measure it in the radiograph, where to wedge, and our team does a wonderful job, and then we repeat the X-ray same time. We see whether the wedging has done its job or not. If it has done its job, we continue the cast, and we remove the cast after 6 weeks anyway.
I was going to ask if you use C-arm. So you don't use C-arm. You just take your best guess at the angle, put the wedge in, and then take an X-ray.
So it's not a guess. We have packs. We measure exact measurement where the wedge is needed. So there are different papers where you have to wedge a cast in adults. So we apply the same principles. We measure on the packs. We mark it on the cast. We tell our ortho practice this is the place where you have to wedge. Either it's dorsal, either it's on the lateral side. So it's all mathematical. We don't need a C-arm for this. We then repeat an X-ray, and we see if, as you saw, we had 3 patients who didn't get wedging correct, but 3 patients in 160 patients is very, very less, Yeah. As I said, it's a standard practice. We measure on packs, the length, where to wedge, correct the angulation, and that's it.
That's a real art. That's amazing. But the kids must scream when you're...
As I showed you, there's a paper on pain as well from Germany and Switzerland. So they do probably the same thing. So they only studied the pain portion of this. So they just say there's a minimal pain when you do intervene, but then the pain goes away. But it is you have to see getting the patient through the trauma of OR, under anesthesia, C-arm pictures, remanipulating. And I will tell you honestly, whenever we take a patient to the OR for remanipulation, like if I decide I will only remanipulate, we end up operating, because we know we're taking the patient to OR, giving an anesthesia, let's put the wires, let's put the plate. Why we want to take a chance with the patient with the loss of reduction again? So it's a huge bonus.
Thank you, Dr. Mansour.
Yeah, thank you very much. This is an excellent thing. I trained in Germany, and we used to do this a long time ago. Of course, we didn't use angulation. We used C-arm, and they call it Gibbs Kyling. So we used to kyle the Gibbs, and with the C-arm, but this is using angulation and predicting how much you need to wedge the cast is an excellent thing. Good luck. Very nice.
Thanks a lot. As I said, it's an art. Thank you.
One question for Dr.
My question is quick. So do you have any issues with pressure injuries? As you put in that wedge and you're pushing pressure with the cast on the arm, are you seeing pressure injuries?
We haven't looked into clinical data, actually. I spoke to our orthoprac team, and we didn't have actually any. So nothing came to our notes except one median nerve palsy, which I have mentioned in my presentation.
One last question. Did you identify any risk factors for failure of wedging in the 3 cases? 3 cases is a small number, I know, but did you identify any reasons that you can avoid in the future? And what will be the management of these cases? Is for surgery?
Yeah, so
because healing has happened in the, isn't it?
So as I said, the wedging cast depends on the quality of the first cast. So while you are wedging, it also will reposition the cast. So there are multiple factors which are known. We haven't specifically looked why these 3 failed. Maybe they presented a bit late to us.
Yeah.
That's one of the
reasons. Let's see if there is any shared point, then we can avoid it and we have better results even. But thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Welcome Dr. Amir, he is here. And we go for the next presentation, Dr. Ali. Dr. Ali will be presenting from Urology Department. Go ahead, Ali.
Yeah. Good morning, everyone. My name is Ali Sweidat. I'm a urology resident. Today's topic would be about urethroplasty without urethroplasty for patients with hypospadias without hypospadias. You might ask me what I mean by this. I'll make it more clear as we go. So I do not have any financial or any other relevant relationships with commercial interest to disclose. So what is it? What am I speaking about? So urethroplasty without urethroplasty for hypospadias patients is a study that we have performed. It's a retrospective study of 7 patients. It's a case series. It's an alternative approach to a hypospadias variant, which has the features of a classic hypospadias with a normal meatal position. So what is hypospadias? Well, hypospadias was first described back in 2 AD by the Greek philosopher and physician Galen of Pergamon. It literally means hypo and spadon, which is the below and under. So it is an opening down under. A hypospadias is an abnormal position of the urethra along the penile shaft, ranging from all the way from the glandular down to the scrotal, and even sometimes we see it in the perineal position. Now, a hypospadias alone, an abnormal opening is not just the definition of hypospadias. We see it as a triad. It is an abnormal opening, it is a chordee, which is a downward curvature of the penis, and we also see hooded foreskin, or in other words, an incomplete foreskin development. In the select patients, we also see a penile torsion, and in many patients, we see a ventral skin deficiency. The ventral skin deficiency actually guides our management in most of these cases. So, in our study, from 2018 to 2023, out of 168 patients with primary distal hypospadias, 7 of these patients had presented with this stenotic or hypoplastic, may I say, distal urethral segment. So what is the conventional treatment for hypospadias? Well, we usually undergo a urethroplasty, whether it was done in one stage or staged. We also do a chordee correction, and we do a foreskin reconstruction or a circumcision. So how would we treat this? I had found out that the videos aren't working here, so I would just like to go back to my first slide. This is a patient coming with all the classic features of a hypospadias, which is the chordee and the hooded foreskin, but with a normal apical meatus, which is normal positioning of the meatus, with a hypoplastic segment of the distal urethra. So most surgeons would actually opt for urethroplasty. We would like to think otherwise. We usually do a urethroplasty even in a conventional treatment, but in our study, we would like to think otherwise due to multiple reasons. This was initially studied back in 2001 by Jetnak et al. It was found out to be a new technique in which we preserve the native urethra. And in this technique, it was never studied back again ever since 2001, and we'd like to reintroduce it. Why? Well, we prevent developing urethroplastic complications such as strictures, diverticula, and fistula, and many other complications that we see daily in the clinics. And we preserve the native hypoplastic urethra, along with the fact that these patients with this technique can go home on the same day, rather than keep them overnight or maybe multiple days as well. So how do we do this procedure? Well, we start off by marking around the hypoplastic urethra. We deglove the penis, right around the hypoplastic urethra. And then we do an erection test, or we can actually assess this also by vision. We assess the erection to see if there's any curvature. In 4 of the 7 patients, we had done a tunica albuginea application, which is a suture of a non-absorbable suture taken in the dorsal aspect of the penis. And we would also correct the chordee. These were the results seen on just post-operative day. And as we can see, it's a straight penis with a uniform distribution of the skin, and he's having a normal urination, a straight stream. This is the result on 3-month follow-up. As we can see, there's an apical meatus and no redundant foreskin and no hooded foreskin. And these are the results of 3 of the other patients seen actually at 2-year interval. What are the limitations? Well, one of the major limitations to this study is that it's limited to the prepubertal patients. Many of these patients could actually develop at puberty a recurrence of the chordee. And another limitation is that we have a limited number of patients. This is only done by a single surgeon, and only 7 of these patients were studied. So in conclusion, all the goals of a hypospadias correction were achieved, which is a circumcised penis with a homogeneous skin coverage, an apical meatus, and a curvature correction. It is catheter-free, urethroplasty-free, and these patients can go home on the same day. And by this, I can say it's mission accomplished. I would like to thank Dr. Santiago and the urology team, and Maria, thank you very much, and thank you. Thank you all.
Thank you very much. Any question? Dr. Hassan?
Yeah, thanks for the nice presentation. Actually, it's a nice way of presenting. The title was catchy. The question is, you mentioned about the chordee that's happened in the future. Is it because of the shortness of the urethra? Is that the cause of it? Is that the cause, then what's the point of the surgery? I mean, from my perspective as a general surgeon, because you're not changing the length of the urethra, and that's the question that please answer.
Yes, this actually covers the reason why we would actually see a recurrence of the chordee, or could possibly be seeing a recurrence of the chordee. The hypoplastic urethra was not addressed properly, or not properly in this case, but we do not have enough data to see if patients at the pubertal age would develop a recurrence of the chordee because of the hypoplastic segment. So these patients could actually be seeing a normal straight penis at the age of puberty, and we do not exactly know. And this is why I mentioned it as a limitation. But yeah, as you said, the hypoplastic segment would be the cause of the chordee recurrence in the future.
There is a point of going through the surgery. So my question is there a point to do the surgery if it's not going to prevent something that is inevitable?
Yeah, well, this is not completely studied at the moment, which is why lots of surgeons opt for the urethroplasty, but we would like to beg otherwise. We would like to actually study this further, even at the pubertal age. Maybe a select few of patients would actually benefit from the surgery due to having a hypoplastic segment, which could not develop into a chordee into the future as well.
I mean, this would be very nice for all the parents to know that they don't have to go through the catheter and through the different complications. I mean, I hope this works well. So
exactly.
Nice work. Thanks.
Yes, thank you.
Still, we have 2 minutes for discussion. I would like to ask, why did you limit it to prepubertal? Now, we know that there is a risk of persistence, recurrence, or aggravation of long-term curvature because of potentially presence or preservation of the hypoplastic urethra. I think it will have a place in post-pubertal patients, particularly that they completed the most challenging period of the adolescence and development, so that if there is no persistence of curvature at the end of the surgery, it's unlikely to recur in the future. So why did you limit that?
There's no data. We don't have the data for the pubertal age, or these patients weren't followed up, and we have only a limited data because the follow-up
So your data is limited, but you did not limit to inclusion criteria. So in the future, if you have the access to adult patients, you can still do it, isn't
Yes,
it?
definitely.
Okay.
Yes, definitely.
So one last question from my side. Do you think to optimize the inclusion criteria based on a more objective, because sometimes objective description, like sometimes the meatal position can be scrotal, but after degloving you will have it subcoronal. So I think if you based on spongiosa bifurcation, it will be more reproducible. Okay?
Yes, definitely, definitely. And we would see different actually results in these patients as well later on when choosing this approach. Yeah.
Thank you very much. I have a couple of questions. So I think it's very nice how you demonstrated that 4% of all the distal hypospadias you treated in this group was of this variation. And I think this, what this says is if you do this technique, you will do 4% less urethroplasties. So that is, I think, an advantage. Is it possible to look at what is the incidence of this type of hypospadias in the general population? Because then that will be more relevant also to general surgeons who do circumcisions. For example, I had 2 similar cases the last couple of months, so it would be also interesting to look at that. Second is a more technical issue. So when you do this curvature repair, you will have to do the posterior Nesbit kind of, and that will always lead to loss of length. So would that be also a downside of this technique, as you're not able to release ventrally and gain length?
Yes, definitely. But I mean, even with a conventional urethroplasty, we're still doing the dorsal plication. I mean, we're still losing that length even with a conventional treatment. So this would not change the length of the penis would not actually be changed with a different kind of technique to just approaching the urethra itself. Yeah. Yeah. And for your comment with regards to classifying these patients, I would agree that even patients, doctors or physicians who are not experienced in treating hypospadias could be approaching this as well. So a general surgeon could have a better approach to this kind of urethra.
Thank you very much. It's very
yeah.
interesting. Thank you very much.
I'm sorry.
Let's go for the next presentation.
Thank you very much. Thank you, everyone.
Good morning. Assalamu alaikum. I'm Dr. Jishar Sainulabdeen from the Orthopedic Surgery Department. I'll be presenting a study on the outcome of displaced pediatric neck of femur fractures, which is a retrospective review of patient data from a tertiary pediatric referral hospital. We do not have anything to disclose. These are our co-authors. So pediatric femoral neck fractures are very rare. They form only around 1% of the total pediatric fractures. And usually they're seen at tertiary referral hospitals. But the complications associated with pediatric neck of femur fractures are significant, like AVN and non-union, and these can have a lasting impact on the patient's outcome. In literature, there are not, the reliable factors for predicting these complications are still controversial. There are some factors like the type of fracture, increasing age, which has been seen to be reliable in predicting complications. You can see the Delbert classification, which classifies these injuries, shows that the AVN rates are highest for the transphyseal, which is the type 1 injuries. Again, non-union is seen to be around 10.8% in literature, and it is basically due to inadequate reduction and non-operative management. So our aim was to review the outcome of displaced pediatric neck of femur fractures, which has come to our hospital in the last 6 years, and to compare to existing literature, and also to review predictable factors which affect the outcome. This is basically a retrospective review of patient data from the last 6 years in our hospital. We have only included displaced pediatric femoral neck fractures with a minimum of 1 year follow-up. We have looked into the patient demographics, including the age, sex, the mechanism of injury, and all these injuries have been classified using the Delbert classification. We have looked into the timing of surgery, the method of reduction, and the method of fixation, and the outcome has been measured using the Rateliff criteria as good, fair, or poor. So in the last 6 years, we have had 14 patients of pediatric neck of femur fractures. out of which 10 were displaced and included in our study. And as you can see, most of our patients were males. Most of our patients were in the 10 to 14 age group. This is something which is seen in literature also. But the mechanism of injury in only 50% of our patients was a high energy mechanism, which can be an RTA or a fall from height. Most of our patients were the Delbet 3 type, which is the basi cervical type. And out of the 10 patients, 9 of our patients had fixation within 24 hours of surgery. One surgery was delayed because the patient was medically unfit. 4 of our patients had closed reduction, 6 had open reduction. Hip decompression was done in 8 of our patients. We have used cannulated screws in 3 patients, locking plate in 5 patients, and a combination fixation in 2 of the patients. We have had 1 patient who had a delayed union and 2 patients who developed AVN. 1 patient developed hip subluxation, but this was unrelated to the neck of femur fracture. This was because the patient developed paraplegia because of the other trauma. So this was the patient with delayed union. This was a 12-year-old girl who had a Delbet 2, that is a transcervical fracture, who underwent close reduction and plating. But this patient subsequently went on to have full union and no complications. This is the first patient who needed a revision. This was a 12-year-old girl with a Delbet 3 fracture who initially had a close reduction and plate. There was a loss of reduction at 2 weeks and it was revised. And this patient also went on to have full union without any complications. This is the second patient who had a revision. This was a 10-year-old boy with a Delbet 3 fracture, had a close reduction and plate fixation initially. There was non-union of the fracture at 6 months and had to be revised with a blade plate. This patient had full union, but unfortunately developed AVN. This is the second patient with avascular necrosis. This was a 10-year-old boy who had a Delbet 3 fracture, who had an open reduction and plating. This was also the patient who had a delay of surgery for around 36 hours. So an open reduction and plating was done. This patient also unfortunately developed AVN. So out of the 10 patients that we included in the study, 8 patients had a good outcome according to the Ratliff criteria. And the AVN incidence in our series was around 20%. This is something which is, again, comparable to the literature. And the age group involved was the 10 to 14 age group. This is also comparable to literature. Most of our patients were in the Delbet 3 group. As you can see in literature, this type of fracture has an 18% AVN risk. And both the patients who had AVN had an open reduction and plate fixation. We could not find any definitive association between the energy mechanism, the timing of the surgery, or hip decompression. One of our patients had a non-union. This is 10%. This patient had a close reduction and plating. The initial reduction was debatable in this case. This was again a Delbet 3, which has a 20% non-union risk in literature. So currently our results seem to be comparable to available literature. Age, fracture type, and the open reduction plating was seen to be predictive of AVN in our series. Quality of reduction was seen to be predictive of non-union in our series. Other factors, we could not find a definitive association. So what is important here is that displaced pediatric neck of femur fractures are still very uncommon and only seen at tertiary hospitals like ours. And it's very important that we have multi-center studies to list the predictive factors which leads to complications and improve the patient outcome. These are our references. Thank you.
Thank you very much. Any question from the stage?
When you do the ORIF, do you use compression plates?
Locking compression plates, yes.
Do you think that has any association with AVN? I'm not sure. Just wondering.
There is an association with not AVN, but the quality of reduction is associated with non-union. So, and open reduction and plating has also seen some evidence for AVN, yes. It could be because of the damage to the vascularity while we do the open reduction plating. Well, initially for all these patients, we try a close reduction, but if it is not, if you don't get a good reduction with close reduction, we have to do an open reduction because quality of reduction has a very strong evidence for non-union. So this is something we have to.
When we plate fractures, we strip the periosteum.
Yes.
But I wonder sometimes, like on top of the periosteum, whether periosteum.
For neck of femur fractures, because the blood supply is, it's different. I don't think the plating directly, because the periosteal stripping from the plate itself causes a problem for vascularity in neck of femur fractures, yes.
Noora.
I'm looking for ways to improve the sample size for you. I noticed that your sample goes up to age of 14.
Yes.
I'm guessing that 14 to 18, 40 years age group goes to Hamad Hospital. Probably, and gets treated there. Would it be advantageous to see how many of these patients end up in Hamad, the neck of femur fractures? Is it more common in the adolescents age group? That might improve the sample size.
The basic thing is pediatric neck of femur fractures are very rare. So even in large multi-center trials, the sample size is like around 20. So yeah, maybe we can increase the age by 1 or 2, but when 14 is an age we have decided depending on the skeletal maturity. So I'm not sure whether it can really impact our sample size.
Okay, thank you very much. So we can go for the next presentation. Thank you.
Good morning. I am Dr. Badar Dhouyani. Actually, I am from Pediatric Pulmonology, but I am happy to present in Surgery Research Day. So our project is about the clinical and radiological characteristic of surgically corrected versus uncorrected congenital diaphragmatic eventration in children. So this is Sidra experience. All the patients operated at Sidra Hospital. I don't have any disclosure to be cleared. So in introduction, diaphragmatic eventration, as you know, it is abnormal elevation of hemidiaphragm, and this could be caused by muscle weakness. This could be either congenital or acquired in some cases, for example, in the nerve injury. So diaphragmatic eventration can be asymptomatic in some cases, but on the other hand, can present with severe respiratory distress. So as you can see, there is a very huge variation in the presentation of such cases. The surgical application of the affected diaphragm is the standard treatment, but unfortunately, there is no clear guideline or recommendation to whom we should operate and to whom we should observe. For that, we decided to do this study. And actually, this is our objective, to compare radiological and clinical characteristic of surgically repaired versus non-repaired congenital diaphragmatic eventration. After that, we looked at the surgery group patient, and then we compared pre-op and post-op. So this is our method. It is a retrospective study of all children with diaphragmatic eventration who were seen at Sidra Hospital from 2016 to 2024. Clinical and radiological data were retrieved and analyzed from the CERNER. Our inclusion criteria, we include all the children who are below 18 years, and they should have chest X-ray to be done, and then to confirm the diagnosis. And we include all the patients regardless of the extent of diaphragmatic eventration, either partial or complete. And our exclusion criteria, we exclude all children who suspected to have diaphragmatic hernia. So we use this method to calculate the diaphragmatic height. Unfortunately, I don't have a pointer, but you can see here on the right side, this is the affected part. And you can see the elevation of the diaphragm in this side. So we calculate the diaphragmatic height. You can see we put 2 lines, so from the dome of the diaphragm to the apex of the lungs, and we take this measurement as the affected part. On the other hand, this is the normal side, the left side, and then we make this ratio, the non-affected part over affected part. At the end, we got a ratio as a percentage. For example, here is 42. So for example, if this patient, for another patient, if the diaphragm is more affected, this percentage will come lower. And we found actually there is two types of diaphragmatic eventuation in our patient. You can see here this is complete, and this one is partial. Only part of the hemidiaphragm is affected. This is our clinical and radiological outcome measure. For clinical outcome, we look to hospitalization, length of stay in the hospital, and we look to normal bed and BICU bed. And also to respiratory support. In respiratory support, we look to each respiratory support, and then also we look to the duration for each of them. Radiological outcome, we look to the degree of diaphragmatic eventuation. We compare also pre-op and post-op. Is there any difference or not? So this is the result. We had a total of 36 children in our study. And as you can see here, the majority are male, almost 2 to 1. And the median age at diagnosis was 3 months. We found that there is 47% had other comorbidities, 56 were symptomatic, but 44% were incidentally diagnosed. In this one, you can see the side of the diaphragmatic eventuation. As you can see, the most common is the right side diaphragmatic eventuation, and majority of them, they have complete diaphragmatic eventuation, about 92%. So in our result, we found that there is around 33 patients who require surgical repair, compared to 66 patients who did not require any surgical intervention. And then we compare between these two groups, the surgery repaired and non-surgery repaired, and we found there is no significant difference between both groups in age of diagnosis, gender, weight and height, side, and extent of diaphragmatic eventuation. You can see here then two groups we compare between the repaired patient and non-repaired patient, and this is actually very important to know that the ratio of the diaphragm, actually there is no difference between operated group and non-operated group. And the p-value was 0.85. But interestingly, there is a significant, finding in the patient who require surgical repair that the majority of them, they are symptomatic. And you can see here the p-value was 0.02. And on the other hand, they are more prone, in the surgery group, they are more prone to have other comorbidities. For example, you can see here in non-repaired group, most of them, they doesn't have any other comorbidity, which is 71%. The p-value was 0.01. Also, we found in the repaired group, they are more likely to be hospitalized. The p-value was very significant, and also more likely to have respiratory support or to require respiratory support, and the p-value was very significant. So in surgery repaired group, we look to the surgical approach. As you can see here, almost they are the same, but thoracotomy is the most, majority of them, they had thoracotomy, 38%, and laparotomy, 33%, and thoracoscopy, 25%. Also, we look to the short-term complication after the surgical intervention. 4 patients, they had complication. 2 of them, they got infection, and 2 of them, they got pneumothorax. And this one, we compare the surgery group, pre-op and post-op, and we compare is there any difference or any improvement. So actually, you can see the ratio of diaphragm, it was statistically significant. There is improvement, and the p-value was below 0.001. So there is improvement in the diaphragm elevation. But on the other hand, you can see there is no significant improvement in respiratory support. Duration of respiratory support also, there is no improvement, and duration of invasive ventilation, actually, it worse or more prolonged. And duration of BICU also, it become more prolonged in operated group compared to non-operated, post-op compared to the pre-op. And the duration of hospitalization was more prolonged also. So you can see here the respiratory support, pre-op and post-op. You can see here the patient who required invasive ventilation remain on invasive ventilation even after the surgical intervention. Actually, and the patient who doesn't require any respiratory support, they remain post-op without any respiratory support, means that there is no significant improvement even with after correction of the elevated diaphragm. So overall, there is no improvement in respiratory support, duration of invasive ventilation, or non-invasive ventilation, BICU stay, or hospital stay. So in conclusion, diaphragmatic ventilation is more likely to be repaired in symptomatic hospitalized children with comorbidities. Degree of diaphragmatic ventilation in XA did not influence decision for repair. Surgical repair resulted in radiological but not clinical improvement. Our limitation, it is retrospective study and small sample size. We plan also to do in the future to make it prospective, and we will include more of to look for comorbidities and pulmonary function tests for these two groups.
Thank you very much.
Thank you.
To conclude, yeah. So it's a very interesting study. I have several questions, but we'll start by Dr. Mansour. He has, he's the chief of thoracic surgery and.
Yeah, thank you very much. Very nice study. Did you share it with your colleagues in pulmonology?
Yeah, I am from here.
Because the problem is that, you know, they are the one who run after us to go and repair this eventration, even though the surgeon think that we don't need to repair it. But because of the struggle they face with these patients, especially when they have a lot of comorbidities, and everybody think if we flatten the diaphragm, the patient will be better. So I really want to present this to everybody in pediatric. Thank you.
So Dr. Mansour, is this different from the literature? Like what we have here, it is a striking finding that surgical intervention does not improve the symptoms. It's only what we can see in the images. So if it is very different from what is in the literature there, then it is a very interesting study and with a lot of impact to the literature. And
so actually regarding, I did the literature review. All of them, they look to the symptoms, but not like what we did to compare between pre-op and post-op, and also to compare these two groups, the patient who is operated and not operated. We looked at everything actually to the degree of improvement in radiological finding, and on the other hand also to clinical, which is very important to us more than radiological.
So the literature says that there is improvement.
We didn't find in pediatric population. No, we didn't.
There is no benefit.
Sorry, again.
So what is the conclusion of the literature about the benefit of surgery in this group of patients? Is it similar to what you have concluded, that there is no symptoms improvement or not?
Yeah, I couldn't find them like our study. They mention the indication is to do for symptomatic patient. Okay. But what is the benefit? What happened to them? I didn't find any. Looks like.
I think this is one of the very promising studies. It's a large number of cases. It's controlled because, as you mentioned, surgery, no surgery. The imaging scoring was excellent.
Next to all of them, yeah.
Exactly. But it will be better if you want to publish it or you want to standardize it to make the scoring system for the symptoms more objective. You cannot say respiratory failure. You need to score it, which grade, what were the parameters, blood and respiratory settings.
Actually, for respiratory failure, we include who require invasive ventilation.
Okay.
So the one who is invasive ventilation means respiratory failure.
Okay, Dr. Amir, do you want?
I just want to mention also that maybe imaging, if we start using MRIs and measuring lung volumes, these things I think will give us more accuracy in respect of which patient will benefit and which patient will not benefit. Of course, these kids, some of them, they are very sick and they cannot be transferred easily, but I think MRI should be also an important tool that we can use.
And I think we should look to each patient individualized. For example, to look what we found that there is a lot of other comorbidities. So we have to assess the respiratory element or respiratory impact in such patient compared to the other comorbidities, if there is any benefit or not. So each patient should be different.
Dr. Amir, do you have a question?
Thank you very much. I think it's a very nice design and control, like you said. Let me ask you, what is the length of your follow-up?
The follow-up? So we plan to make it prospective. So we will look to the patient as in future, we will look for a pulmonary function test, and if there is any relapse in the X-ray, we will follow them out as outpatient.
Yes, because if you allow me to take the adversarial seat, it's to state a negative statement that there is no difference. I think I would like to see like the length of the follow-up, more parameters, and I would like to know if you have enough numbers to say that there is no difference. Maybe you need more numbers to see the difference. But certainly, from these findings, there's no striking difference that meets the eye immediately. But I think in order to be like definite and have like an impact, then you need to have more details about the length of follow-up, all the parameters that you have seen, and is there any change in the setting, in the ventilatory settings, as opposed to just ventilation versus no ventilation and things like that. But I think...
Actually, regarding them, the most of them, I think the main indication was to do the surgery is to for the patient who require respiratory support and who were admitted or severe respiratory symptom or respiratory failure. This is the main reason when to do the surgery. And we look at the ventilation for each patient individualized. I have a slide here, if we have time. How to go from down? Yeah, this one. Yeah, this one. So this one is the respiratory duration pre-op and post-op for pre-op and post-op. As you can see here, in the left side, the respiratory support before the operation, and the right side post-op. Actually, you can see that it is more prolonged. Each patient is in the one line. And most of them actually, it was very significant in the invasive ventilation. Actually, they are more prolonged. And this is the main indication to do the surgery in our hospital, what we found. Yeah.
Yeah, just a very quick, naive question. Why do you have, why is this more prevalent in males and females, 2-to-1 ratio?
Yeah, we found this is the incidence. It happened with the male more than female, 2-to-1.
Do you have any idea why?
No, I don't have any idea. Then we need to look for a genetic... Maybe...
Thank you for a good presentation. Just a question I wanted to understand. I'm not sure if I missed it from the beginning. Is the eventuation the same thing as diaphragmatic hernia, or is it's a different?
Different. So actually, any patient suspected to have diaphragmatic hernia, we removed it from the study. Okay. Otherwise, we will have a huge number. But our aim is to look for diaphragmatic eventration. The indication for diaphragmatic hernia, it is very clear, it is indicated, and we need to operate. Okay. But diaphragmatic eventration, till now, there is no clear guideline to whom we should operate. And as you can see here, a lot of patients found incidental finding, and they are living without any issue. This is Dr. Mu'tasam. He is my supervisor in the study. And Dr. Noora.
Thank you. So this is more of a comment than a question. So it was really a surprising results for us. And just to comment on Mansour, it's true. We admit the guilt of trying to push the surgeons all the time to repair them. But we're all biased because the patients are symptomatic, they're hospitalized, they're on respiratory support. But the striking finding for us, the fact that those patients did not really benefit. So that really pushes us now to question our decision. But also the question is why they did not get better. It looks like the diaphragm doesn't play a role in improving the symptoms here. So it could be because the underlying comorbidity is the reason why they're symptomatic. This is the reason why they're on respiratory support, or because maybe fixing the diaphragm, it fixes it anatomically, but it doesn't improve the function. So maybe these are the two possible explanations. But really from now on, I think we should question, and I still would say we should not repair them. I think we should individualize the decision and try to think how much the diaphragm eventration really plays a role in the symptoms and the respiratory support.
Yeah. Okay. Thank you. Thank you.
Good morning, everyone. My name is Houda Kilani. I'm the care coordinator for the Cleft and Craniofacial Clinic in the Department of Plastic Surgery. So I have recently gained a degree in genetic counseling, and today I would like to share with you my research project as part of my thesis. Since I work in plastic surgery clinic, I thought I would do my study on our cohort of patients. So I chose the topic of parental knowledge and attitude toward genetic testing and childhood genetic counseling. So I will start with an introduction to the topic, the literature review, the methodology and study design, resultant discussion, and then we will conclude. So congenital anomalies are structural abnormalities that present before or at the time of birth, and they are estimated to be around 2 to 3% globally. They can present either as an isolated form, such as cleft lip and palate, microtia, or as a part of a syndrome, such as Apert and Down syndrome. Causes of congenital anomalies can vary from environmental influences, complex or unidentified genetic factors, or a genetic factor such as single gene pathogenic variant, or chromosomal aberrations, and these are the two most common causes of syndromic malformations. Consanguinity can increase the prevalence of these genetic malformations, especially those inherited in a recessive pattern. So with the widespread use of genetics testing, it became more cost-effective to screen embryos, fetuses, and children with congenital anomalies. So the demand for genetic counselors become high as these healthcare professionals can help with interpretation of complex genetic information for both parents and healthcare providers. Ethical issues, however, are a hot topic in a pediatric setting, as the decision to do these testing can have lifelong implications on children. So although there is ethical concerns, there are potential benefits, as identifying serious health issues early can allow for timely intervention. And the benefits to do them rely mainly on parents or legal guardians' understanding to do these tests and their willingness to pursue them. So we did a literature review, and we found that the majority of the studies were conducted in the Western countries. However, only limited studies on this topic was conducted in the Arabic region, and the majority of the participants were mainly having a positive view toward genetic testing, and their influence to do them was mainly the decision for them to do these testing were influenced by socioeconomic factors. So Qatar population is diverse, with the native Qataris making up to 11%, this is a typo, and the high consanguinity rate among native Qataris were estimated to be around 54% in 2006. So Qatar National Health Strategies places a high priority on the well-being of children and pregnant women, and the strategies included the investment in premarital and newborn screening, as well as the advanced in genetic testing to ensure high quality of care. So here in Sidra Medicine, the Department of Plastic Surgery provides a world-class care for children with congenital and acquired anomalies through a multidisciplinary team of specialists. Although we don't have a geneticist or a genetic counselors in our team, we do have direct in-house referral to the clinical genetics. So our study aim is to assess parents' knowledge and attitude toward genetic counseling and childhood genetic testing, and explore how these perceptions of benefits and barriers can vary across psychodemographic factors. So our study design was made of a prospective face-to-face questionnaire that was completed online using SurveyMonkey. We were able to capture 160 questionnaires. Our inclusion criteria had any parents attended our plastic surgery clinic between October 2022 to February 2023, any parents of a child with congenital anomaly between the age of 0 to 17. So our questionnaires were adapted from previously described questionnaires in the literature. It included 37 questions, and it was made available in both English and Arabic language. All data were coded and analyzed using SPSS software. And now to the results and discussion. So the majority of our parents had a child with 60% of our parents had a child with a isolated malformation, while 40% had a child with a syndromic or a multiple congenital anomaly. So when it comes to the nationalities, 27% of our parents were Asian, 25% were North African, 22% were Qataris, 20% were Middle Eastern, and only 6% were American European. When it comes to the education level, we found that half of our parents, 50%, had a bachelor degree, while only 19% had a high school or less. 23% of our parents were consanguineous. 34% of our parents were actually referred to the genetics clinic by their healthcare provider. And among those who actually visited the genetics clinic, they found 72% found that the consultation helped them in the understanding of the contribution of genetics to their child's congenital anomaly. 74% of our parents, they were actually considering a referral to the genetics clinic if it was proposed by their healthcare provider. 70% of our parents were actually willing to be referred to the genetics clinic if it was not being referred in the past. So 94% of our parents scored a moderate to high level of knowledge toward genetics, while only 60% had a low knowledge level. And actually this study, our study findings, was actually aligned with another study that was done in Qatar in 2020, where they found that a significant proportion of the population in Qatar have a strong understandings of genetics. So when we looked at the association of the parental knowledge and demographic factor, we found that ethnicity was a significant factor, where the American and European had a higher knowledge level compared to others, nationality. We also found that education level also was a significant factor, where the parents who hold a high school or less had a lower knowledge level compared to the other. When we looked at the attitude towards the perceived benefits and the demographic factors, we found that parents who are consanguineous and those who had undergone genetic testing in the past had more perceived benefits than the others. We also found that parents who were referred by their healthcare provider had a higher perceived benefits than the others, and this actually underscored the importance that the clinicians play in promoting the understanding and the acceptance of genetic testing among families. So when we looked at the listed perceived barriers, a substantial majority of our parents, above 55%, expressed their disagreement with the most proposed barrier, except when we asked them about the potential impact on private health insurance and the cost of genetic testing. We found that 52% of the parents were not sure whether the health insurance will be impacted by the genetic testing, and 46% found that the genetic testing was actually expensive and it was a barrier for them to pursue the tests. When we looked at the correlation between the perceived barrier score and knowledge score, we found that when the knowledge is higher, the perceived barrier is less, and vice versa. And when we looked at the attitude towards the perceived barriers and the demographic factors, again, ethnicity came back as a significant factor, where this time we found that Qataris had more perceived barriers than the other nationalities, while American and European had the least perceived barriers. So we can say that ethnicity was significantly influenced how people perceive their barriers and benefits toward genetic counseling and testing, as different ethnic groups have faced a unique cultural, social, and economic challenges that can impact their willingness to utilize these services.
Dr. Houda, can we conclude?
To conclude, clinicians play an important role in identifying cases that may benefit from a referral to genetics clinic and significantly influence how parental decision regarding genetics testing. Parents with lower education level may require extra assistance in understanding the genetics concept effectively. Culturally sensitive and tailored education on genetic testing is essential for better understanding and acceptance with various ethnic groups. And integrating genetic counseling service into the plastic surgery team is vital and important and crucial for providing comprehensive care and to enhance the patient experience. I just would like to thank Dr. Mitch Stotland and the plastic surgery team for their support during my thesis journey. Thank you. Any questions?
Thank you very much. Question for Dr. Noora there, yeah.
Thank you very much, Houda. This was really exciting. I applaud you for getting 160 survey back in 4 months. So that's a great feat. Did you use a ready-made questionnaire? And if so, did you validate it in a way for our society, especially that you went for both English and Arabic?
Sure. So what we did is we have adapted this survey based on multiple literature studies on the same topic. And the questions were validated by 2 certified genetic counselors And we also validated through, we did a test with a couple of parents just to make sure that the questions are clear to be understood in both English and Arabic. So, yeah.
I think it's very, very important to study, but I want to understand something. Is it clinically indicated to do these genetic tests for these patients, or you want to do it for research purpose?
Yeah, it is actually indicated for even...
Clinically indicated?
Yes.
Okay, so you search about the understanding about what is happening in the genetic analysis, what's the benefits and these things.
So mainly we were trying to understand the parents,
Perception.
Yes, exactly, their perceptions.
Excellent. And what was the response rate? Like how many surveys sent and how much you received?
So we have...
100% of them replied to you? 50%?
So actually the questionnaires was handed over to the parents when they were visiting us in the clinic.
So 100% response?
Yeah, so they were actually installed on an iPad, so we gave them to the parents and they gave us the questionnaires back, after they consent, of course.
Excellent, thank you. Any other question? Dr. Amir?
What is the impact of the result? Do you recommend any policies or any hospital attitude towards it?
So I would highly encourage that clinicians identify the cases that they would require or they would benefit from genetic testing and therefore make the referrals to the genetics clinic. From my own observation, I found that there's a lot of patients that come to our clinic that they visited actually other clinics and they have nobody have actually identified the reason for a referral to the genetics, so it's a gap. So I feel like clinician needs to be more aware and refer cases, to the genetics clinic to get the benefits of the genetic testing if the patients want. Yeah.
Okay. Houda, a nice presentation and great job. One quick question, I'm not sure I missed it, but when you compared your results to the survey that was done in Qatar, I think the results were very clear. But when you compare it to the studies that were done in Jordan and Saudi Arabia, were the results similar?
So we didn't find a study that was done on parental understanding on children, on genetic testing on children. So what we found is that was actually a population-based studies that was done in Saudi Arabia and in Jordan, not particularly to, parents of children with congenital anomaly.
Do the results typically align with what you see? Because when you compare to the population-based Qatari study, the results were fairly similar, where the majority would fall in the moderate to high level of knowledge.
Yeah.
Were they the same for Saudi and Jordan?
We did not actually find something that we could compare with in the region, but yeah.
Thank you.
You're welcome. Questions?
Yes, Mansour.
Okay, so thank you, that very nice presentation. So my question is that you mentioned that 40% they have multiple congenital anomaly. These patients did not receive any genetic counseling before they came to the plastic surgery?
Not all of them. I can go back and show you the other variables and the results. Not all the 40% who had a congenital or a multiple comorbidities actually had a referral to the genetics clinic. We have a big gap. We're actually putting together another proposal where we also found that there is a high percentage of the parents were not
because that part is very important, how many of these patients, they should have been already, or their parents have already been counseled before even coming to plastic surgery. So we have to talk to the neonatology department or the pediatric department, because unless these patients are born outside Sidra, which is another issue, so should be a communication with HMC, for example.
Of course.
That's it. Thank you very much.
Thank you.
Thank you. Thank you, everybody.
Welcome back, everybody. Now we have another engaging segment, and to help us with this, let me introduce you to our moderator, Senior Attending Surgeon of Orthopedics, Dr. Kaysar Chaudhary.
Welcome back. Hope you're all refueled, recharged, and ready for this next section. So we're going to have a very good presentation from Stephanie Dilling. She's our trauma program manager here at Sidra. She plays a very key role in enhancing trauma care making sure our hospital meets its trauma standards. She's got a strong background in emergency trauma management. She oversees development and implementation of a lot of the comprehensive trauma protocols that we have, focusing on patient outcomes and quality improvement. Her roles involve coordinating with medical staff, assessing and enhancing trauma care policies, managing data collection, and also leading community education efforts. She's instrumental in conducting a lot of the case reviews that we do, monitoring compliance with the regulatory requirements, and also that Sidra maintains its commitments to excellent trauma care. As you'll see from the presentation, she's got a keen analytical mindset and a very good collaborative approach. She engages with all healthcare professionals to improve trauma systems for the patients, and her dedication is reflected with active participation in these events and also the MDT approach that she envisages. So without further ado, Stephanie.
Hi, good morning still. I think they may have oversold it with engaging and dedicated, but we'll jump in. So one of the things that we did that we identified, we wanted to build a dashboard for trauma to build a little bit of visibility, to be able to start tracking our KPIs, and since the trauma program goes across all of the different disciplines, to make it easier for people to get some of the data they want. So this is our journey. No disclosures from me. For my learning objectives, Maria messed up and gave me a lot of time to talk, and I love trauma, so we're going to cover a little bit of trauma, understanding trauma data collection, and then we'll look at our dashboard discussion specifics. This I borrowed from Dr. Guy. The best way for a surgeon to learn about injury care is to follow an army. So the biggest advances in trauma care have come from wars, unfortunately. Things from different clamps, tourniquets, blood products, fluids. But unfortunately, we do manage to break ourselves with or without war. So accidental injury remains the leading cause of death in the pediatric population for all children under the age of 10 years old. This is a stress on our services because trauma is always unexpected. There's nothing planned when they show up in the department in the hospital needing care. Global shortages worldwide lead to that stress being increased as the larger and larger patient populations in the emergency department and the hospital. Decrease in the availability of services that general practitioners used to be able to provide in their offices now have to be done in hospital. When I grew up, your doc would do your sutures, at least remove them, and now a lot of that has to be done in hospital settings. So trauma care is very complex. Anyone who manages these patients is aware. And part of it is because it's not anything set. You don't have a set thing like you would if you knew you had a medical process, if you knew you had an appendicitis where you do ... Trauma care, you can have people that not only have the same mechanism of injury, but are in the same, perhaps, vehicle when it crashes, and one of them may have abrasions and bruises, and the other one can suffer devastating injuries. So as you're trying to care for these complex injuries, complex family issues, trouble with staffing, trouble with supplies, you also have other people who email you asking questions because the documentation was missing something we wanted. So apologies for that ahead of time, but there are reasons we want that documentation. Some of you, I can tell, have received emails from me in the past as you giggle, so. Why do we want the data? So for me, data, it helps us turn anecdotal observations into project studies, guidelines, and best practice. Without collecting that data, the things that you see at the bedside, you can't either verify or you can't roll forward into better guidelines at your hospital or even extend it globally. So, I mean, and this is from simple things, from nurses back when they noticed that the babies that were by the window were less jaundiced, and so they started rotating the babies, to tourniquet care. Tourniquets originally were used, then they stopped using them to save limbs, but then we maybe wanted to save lives, so you went back to using tourniquets. But now, I'm from Texas, and so a lot of injury talks are focused on car crashes, football injuries, things like that. So there's a lot of data out there on how you get injured, what happens, what you expect to see. So the mechanism of injury is very important. And a lot of times as a clinician, you're looking at what comes in the door. You're looking at assessing that injury. But a lot of times we need to know the why. So when people think of Texas, you see the cowboy. Everywhere I've gone in the world, if people hear I'm from Texas, immediate answer is, oh, cowboy, and they usually let me go where I need to go. So Texas is a very large state. I come from Houston. Houston is the 4th largest city in the US. So even though we have our classic picture of cowboys, we do have big, large metropolitan cities. We have a lot of car crashes, a lot of violent crime. Houston is the largest city with 2.3 million people. In the greater Houston area, you've got just over 6 million once you get to the suburbs. But a lot of the population is focused in these small cities and rural. So, and again, we do like to start our people playing American football young, wearing their pads and helmets already because of concussion studies. So I picked something else to look at today for mechanism of injury, because when I read something that says the patient fell, it doesn't always tell me a whole story. These are good days at the rodeo. You know, if you think about trying to ride a 2,000 to 4,000 pound bull, and you know, if you're a 150 to 200 pound man, there's a lot of mechanism that goes on even if it's going well. So this is a champion bull ride in Texas, and then this is one of the best steer wrestlers in the country. And so what he's actually doing between his horse and the steer, grabbing it by the horns, is on purpose and beautifully done. So that went well for him. That was one of the championship rides last year and won him a lot. So these are bad days at the rodeo. What also will come in the door. So this is when you disagree with families or bulls. And then this is when you start to rethink your career, as you have fallen off. I mean, your key answer might be don't ride bulls, but why would we do that? And you guys may ask, why am I looking at rodeo pictures? Because we're a pediatric hospital. In Texas, we also like to share rodeo with our youngsters. So the middle picture is mutton busting. You put your 3 to 6-year-old on a sheep, tell them to hold on, and they see how far they can go. No handle, no nothing, but they do sometimes now wear helmets. And because trauma is almost always male dominant, also representing the girls, this little girl on the left, she won last year in Houston. She was the best mutton buster in the group. And then the little girl on the right, that when you're older, you get to rope calves, and she roped a goat. And so you have to catch them first, flip them, and then tie 3 of the 4 legs. And she was the winner for that. So girls we do strongly represent with trauma also. But when you can capture what has happened, you didn't fall, you didn't get hit by a bull, you can get some of those better information about what presented the mechanism of injury. It has led to some studies that you can get some safety equipment for rodeo. So they now have vests with plates. They do have the thicker neck braces that help prevent the hyperextension of the neck. A lot of the guys you can't see under their shirts, they have their arms taped for hyperextension of the arm because they're hanging onto that bull with one arm on what looks kind of like a luggage handle. So the other one's supposed to be in the air because you're having a good time. But they do have a hard time getting the cowboys to wear the safety gear because they still want to look cool. But they have seen, the studies have shown that wearing the protective vests and some of the other gear does help with the minor to severe trauma, not as much with the fatalities, because if you do get trampled by a large bull, there's not a whole lot there other than, you know, rethinking your career. So collecting data, doing these studies does lead to changes in trauma care, changes in safety equipment, recommendations, and then even laws once you've shown that these safety interventions can help. So brings us back to Qatar. I do like to tell people cowboys and Bedouins were kind of the same. We may jump on a bull where you guys choose camels, but it's not always well thought out on how that happens. So trauma in Qatar, we have 2 tier 1 hospitals here in the country, and then we have the other public hospitals scattered around. I do love this picture of one of the ambulances that goes out to the dunes. So Sidra does pediatrics, 14 years and under, and Hamad does adults. So the agreement is with EMS, when they get their patients, they sort them. If they think they're this age, they come to Sidra. If they think they're this age, they go to Hamad. Sometimes that works out well, sometimes it doesn't. We end up with each other's patients. Our agreement is that you stabilize them, look at them. Can we treat them here? Are they stable to transfer? And then they either transfer or stay. But, so, we all try and speak one language. Since we open together, we are a smaller country, it's great. We do follow the same format, the same process. We do follow the North American model at this time, and so it keeps us speaking the same language. We collect the same data from all of our charts, whether they're adults or pediatrics, and it all goes into the Qatar Trauma System registry. So having this collaboration between the hospitals has led to some great changes. One of the best for me is Sidra became the pediatric tertiary hospital, which was an agreement between Hamad, Sidra, and the ambulance services. We opened our helipad, and people are calm with it now, but they used to go take pictures every time they had one land. Ambulance services uses our recommendations for tranexamic acid, for epinephrine, and then even now they reach out if they've working on their croup guidelines, their asthma guidelines, they want to know what we're doing. So we're consistently giving the same care from injury all the way through. One of these I did include, there's a supraglottic suction endotracheal tube that they did go live with. It was a great collaborative process between Hamad and EMS to help prevent VAP. This was early on when we first switched over and became part of the Qatar trauma system. It was great collaboration. The only piece was they missed letting us know about it. So we weren't in on it, so I did include it because there are some early bumps. So the first time one came in, no one quite was sure what this was. So our data registry, after they come in, you've done your charting, Stephanie may have emailed you asking follow-up questions. This is the stuff we pull for every single patient. This is the regular patient who falls off, has a bruise, has a bump. We want to know all the information about where it happened, how it happened, what we found. The more complex the patient, if they had procedures, whether it's EMS putting on a pelvic binder, whether it's putting on a cast before they go home, all of the procedures are captured and followed for any complications. So it is very broad, and so we do have lots of questions. This is how I feel when I reach out to you guys needing more documentation. I suspect this is how you feel when I reach out to you asking about documentation. Again, with the global shortage of healthcare and challenges just getting staff anywhere, it is a challenge getting the documentation in. So timing can be extensive, as I think you guys have heard this morning. We do have that on the backside as well when we're putting things into the registry. You can have under and overcoding. You can have misunderstandings of the dictionary that they give us. It is about 250 pages when we read through that clearly defines what we do and don't use. I'm lucky-ish. We have 1.5 registrars because we have one full-time registrar, and then Beverly and I'm not sure if she's here. Beverly and I supplement to help Agnes get that put in. Hamad has 13 registrars. So they have a little bit more challenge with keeping their consistency. And unfortunately, because we're a small team, it's hard to keep up, but we also do have really good consistency. So now that the data is going into the registry, what do we do with it? So since we started with trauma in 2019, we give monthly reports to the ED for their quality, their KPIs that they've asked for. That's matured. Originally, when we first opened, they had different questions of what they wanted to track. And as we've had trauma longer, they ask of different things from me. I submit monthly or quarterly, depending on surgical needs, and then we submit annually to the board. We do submit to PEDS TQIP now, which I'm really excited about. And so pediatric TQIP, there's 166 pediatric specific trauma hospitals in the US that we benchmark our data with. There are 3 international sites, the rest are in North America. So this is just a quick shot of what it looks like. And again, this isn't stuff that everyday people maybe want to see in the registry. And so, but it's interesting to me, the top right is our mortality, and we are in line with our mortality with our cohorts in North America. If you guys want more information, feel free to reach out. So, the process of starting to share our data, to be transparent with all the services who work hard with these patients, started with Dr. Noora. I hope everybody has a Dr. Noora in their corner at some point who says, we're doing this, how are we doing it, what do we need? And her little notebook, so, because she keeps great notes and she's really good at keeping us online. So she kind of helped get us all together, and she got Dr. Ali Afi from the ED to come participate with us, and then she roped in analytics, whether they wanted to help or not, to help everything get set up. We had agreements, we had a plan, and then it was emails back and forth, lots of meetings. So as we were first developing our dashboard, we were looking at what do we want? What's interesting to me? What's interesting to surgery? What's interesting to ED? Because those are all very different things. So we thought, let's start with looking at what's out there. When we looked at what was out there, we were super excited because we loved some of these dashboards. This is one of my favorite from Virginia that EMS puts out. It's great. It shows all their age groups. It shows what types of injuries they're seeing and where they've taken them. And if you look at the map across the region, it shows the darker blue is where you have higher incidence of injury, but then the dots are the different designations for the hospitals, whether they're pediatric or burn units, so they know where their patients are going, and then all of their classifications, how they get there, et cetera. So we loved some of this stuff, but we realized that wasn't feasible for us. So Noora roped us back in and said, this is great. but we can't do this. So what are we going to do? So first we looked at how we wanted to share it. What do we have available? And so Tableau is what was currently available, and so that's what we worked on building. The highest challenge that we had was, how do we identify our trauma patients? Our trauma patients come through the ED. They're direct admits to ICU. They're direct admits to the ward. The majority of them do come through the ED. So I can't just say all patients in 5B are trauma patients, because the patients go to the ICU, they go to wards, they go to 6A, they go other places for overflow. So she helped us identify our problems and what we had, and made sure that we had support for the build. So as I said, our first problem was identifying the patients. Beth Weishman in the ED, they were working on a build for us already that does help identify. So when they walk into quick triage, this is in the first chunk of time, the first time they're seen by Sidra staff, they can flag if they're a tier 1 or a tier 2 trauma. So we had this build identified in September to go live, and the nurses started with it, so it was a great start. So the pro was it was already built, it was already done, we didn't have to create something else other than the link. The con is that this can be missed in quick triage for lots of reasons. Sometimes families aren't clear in what happened, sometimes they're not honest in what happened, or sometimes you find larger injuries than you expect in the mechanism, because sometimes something little turns into a very large injury, and then it misses the direct admits completely. So we do have some future solutions. A consult order to the trauma service would allow us to identify these patients, and a physician power form we're working on with the ED. So challenge number 2. So we had all the things we wanted, and then we had to cut it down. What can we get from Cerner? And so we went through identifying the things we cared about. Is this somewhere right now in Cerner we can pull from a tick button? And so we went through and we found the things that we could identify. So, and then it was clinical people communicating with analytics. And this is what we want. This is where we think we can get it. So what we did was we took what we wanted. We found similar dashboards that were already existing in Tableau, and we said, hey, you did this for them. Can you do it for us? So we worked very closely together with them to do that. And then our third challenge that we have is still out there, making plans for future improvement, because we do want to include some of the data that matters more to people. We want to make sure that we're collecting all the data we can in a live fashion to meet our KPIs, to be transparent with everybody. So some of these would be static, some maybe could come from Powerform. We're going to work on it. So here was our first go when the trauma dashboard first came out, so that we could validate. So what we did was we ran the patients it found, we looked for who was missed and who was accidentally included, because those happen as well, and we want to make sure we're tracking the appropriate patients. Beth has done a lot of work with the ED nurses. We're currently up at about 80% compliance, and then there's surprisingly about 10% where it's flagged inadvertently, and I'm not quite sure why, but they do tend to flag them as tier 1s, which is our highest priority of trauma. I'm not quite sure why that is, but we are working on that. And then this was the other data that came out. So as I was saying, this was our validation process, going through, looking what the dashboard gave us. Is it the right patients? Did we make a mistake somewhere in our mapping or in what we spoke with analytics and Cerner about? So our rollout, we don't want to roll it out until we have a minimum accepted number of patients. And with the caveat that originally the dashboard is a tool. It works for average data information. And so that's why part of what we picked was, what are we seeing? How many T1s? How many T2s? What are the nationality? What are the ages? What are the sexes? The biggest piece that people want is the mechanism of injury. And right now that's all free text. We don't have a good way to capture that. But so this is our dashboard. I can click on it maybe, but you won't be able to see it for the people online. So this is what it looks like today. This is our update from this week. So the tier 1 trauma, tier 2 trauma, if you click actually on that tier 1 section, all of the demographics here, gender, nationality, age, and ICU, those will all, they'll change. So then you'll see those demographics only for the tier 1 patients, and same for the tier 2 patients. If you've selected you only want to look at tier 2 patients. Again, we went live with this click for the nurses in September, and we're still working on improvement there. The other thing that we care about with trauma is what resources are we using. Blood products, we're working on trying to get in maybe in the next month or so, but right now you can see how many of the patients go to ICU. And Jawad doesn't know yet, but ventilator days is what I'm hoping for as well. So OR-wise, since we are a surgical day, these are how many go to the OR, not just for procedures in the ward, not just for procedures in the ED, but physically go to the OR by their priority, and as well as the subspecialties that have taken those courses. Surprisingly, orthopedic definitely represents in trauma. and then radiology, how many of these patients are going to radiology, and how many images they're getting. So in this, I think the selection from the top was for January, and so there may have only been 17 patients there, but there were 196 associated orders from radiology. The only piece that isn't, it's kind of radiology, kind of not, this CV is actually the ECGs and the echoes. I left it in at this time because I do feel like some of that information is valuable. I don't quite know if that's where we want it to end up living, but all information is good information. So there you go. I went through as fast as I could. If you guys want me to go back to any slides, I'm happy to. Or we can bring the panel up and try and ask some questions. I was too long yesterday, so I had to talk faster today.
Okay, have we got panel members to come down onto the...
We had Hassan and Jawad, and I think Dr. Ali Afi was going to try and attend from the ED. Oh, because of staffing. Oh, is he online? Okay, perfect.
Thank you. Questions, please. Thank you.
Hi, Stephanie. It's great work, and I should probably know this, but and I was trying to pick it up from your presentation.
Yeah.
Are you only looking at patients that are admitted?
No. So it's hard to see on this one. We're looking more at the resources on the admitted patients. I didn't take the slide from, I can go online, but then you can't see it. I can click on the live dashboard. But so when you come to this page, it does show you who admitted and who didn't. But no, the radiology images would be for anyone, whether they were admitted or discharged.
And then...
Because the only identifier right now is whether they get that flag at quick triage, and that includes them in our numbers.
So trauma, does it include nasal fractures, hand fractures?
Only if it's going to be one of our major traumas. So it's the tier 1, tier 2. I know a big piece that Dr. Aliafi wants to work on as well for the ED. I don't like to call it minor trauma because a lot of those traumas are pretty significant, but if they're not in our tier 1, tier 2, if they're more isolated injuries, then I think the plan is that we're going to work on something separate for those. A lot of those are going to be the orthopedic, the facial fractures. So if there's a facial fracture involved in one of our polytrauma patients, it will be captured, but it won't be every injury that comes to the ED, if that makes sense.
So isolated would not be included?
Not in my stuff. My stuff is clearly for the major trauma dashboard, tier 1, tier 2 activations. But like I said, I do know that there's a lot of work, and Dr. Aliafi feels, I don't know if he's online, I don't know if he wants to chime in, but he definitely, I know he feels very strongly about making sure we're representing data for all of the injuries that come in.
That would be great, because we do hundreds of hand fracture and nasal fracture, facial fracture cases a year.
Yeah.
And we don't have the resources to really do our own registry. We've tried, we've talked about it, but there's thousands of patients being seen in the ED and hundreds that come to surgery, and I wish we had, we could,
I mean, some of it we could pull off, but like I said, it would only be the pieces. So if you have an ATV rollover that involves some facial fractures, you would be in the population, but I'm not able to at this time look at all injuries.
Yeah, just coming back to Mitch's point. This is actually what Stephanie's work is mainly about traumas, T1, T2, but there was a discussion recently about how to come across the other injuries that has been, she doesn't want to call them minors, but they are the isolated injuries that need to be cashed up. But the focus was today about the trauma itself, but this is also in progress. So they are working on the tier one traumas at the moment and multiple injuries, but this will be also in the plan to catch. So they are working on it, and I think they will come in a way that it will be cached in the main dashboard. Therefore, for collecting data will be easier. So that's something has already been mentioned. But today's work was mainly to focus on the major traumas that come through the doors and how to catch them. And then the next step will be the isolated injuries, as you mentioned.
So thank you, Dr. Mitch, because your question is probably on the minds of other people as well. We brought this up here today because it could be an example for future dashboards. Maybe maxillofacial isolated injuries do not belong on that big dashboard because they will be overwhelmed and maybe not clear, kind of, not classified, but on a separate dashboard. So this tells you it is possible. Leading to that, there are some challenges with that. So you need to do some background kind of work on the documentation and how it's captured. Maybe Stephanie, can you highlight the top 1, 2, 3 challenges for you to say, this is a good source of information, and that's where we told our, Mr. Jawad, our friends from IT, this is a good way to capture what information I'm requesting.
It's a good way to capture it, but the issue is that there's a human component, is that button has to be clicked. And I know I'm always kind of surprised when I audit the charts. A lot of times someone will take the time to type in tier 2 trauma, but not click the button. But some of that is education, some of that is reinforcement. And so Beth and I have looked to try and sort, is there common, oh, go ahead. Oh, about that. Well, so you have to identify it because you guys all do a ton of charting. And so it's just finding the value. When you validate anything that's coming into Tableau, you've got to make sure that that button that you're clicking, that all of us are clicking the same button. I'm going to cheat and pull Dr. Leese into this. So we were talking just a little bit ago about the neuro-obs. And so it was built kind of from the perspective of making sure all of the things flow certain ways. But then on the build, it wasn't all flowing, whether it came from PICU, ward, or ED. And so it's just making sure you've identified all the pieces, where we're charting, if that's what we want, and to pull it in. Because sometimes from an analytic perspective, they see a button on their end that says this that would make sense. Because I know on this, one of the things here, I think for the reason for visit, that's a free text, and that just says unwell, and that's not super helpful for me. That's not a diagnosis or anything. But for an analytics person, when they're looking at, and I said I needed a diagnosis, that would make sense, you know. And so some of that is just working really closely together, either online or phone or in person, so that I can say what I'm wanting, and if I know where I chart it, because when you chart every day, you know what you're charting where. And you know your free text versus your click buttons. And so what you can pull from flow charts. It's just really got to be a really close relationship of what do we have? Does it work? If it doesn't work, what's our plan on how we can get that? Is that?
Yes,
okay.
So for us, trauma is a huge umbrella, and trauma 1 and trauma 2 are not, well, we receive the text on the SMS, but they're not classified that way on the chart anywhere. So Stephanie figured that that was problem number 1 to solve. She came up with a button that needs to be clicked. By whom? By the nurses, that when they check in the trauma, they then classify as trauma 1 or trauma 2 according to a certain set definition. So when we come to, let's say, maxillofacial, that button I think has to be created. Unless you say our CPT diagnosis on admission are accurate. Majority get admitted, I don't care about the ones discharged. If you say that, then can be captured. That's the main challenge for identifying. And then of course, under trauma 1 and trauma 2, we want to identify certain things like blood transfusion. That's not clear. Where do we get that from? From the orders? It's not always there. Did we consider it, but we didn't do it? That's also not clearly there. These are some of the things and challenges.
Yeah. So blood transfusion, like I said, that's what he knows that we've talked about this. So in the bottom right of the screen, again, that's kind of what I did, was I dug through a lot of the different tableaus, seeing what people are reporting. Because if they're reporting it, they're getting it from somewhere. And so it's kind of thinking outside of the box. What do I have? What do I want? What are other people doing? And then trying to kind of pull it together. The challenge with the button is it is recognizing, just like the physicians are trying to decrease their buttons they're pushing, so is nursing. And so if you're trying to create something and telling another team to do it, you've got to have recognition that it's got to make sense and it's got to be feasible. Like Dr. Mitch was saying, if you're creating a whole form, that's a challenge sometimes, you know, and does it replace what I'm already doing? Is it an adjunct? And I think the ED does do a lot of this. I know they've got a new form for their intubated patients, I believe, but it's a very short to the point. And so it doesn't replace their documentation, in my understanding. Sorry, I'm looking for a nod to make sure I'm correct. So it doesn't replace what's going on, but it is an adjunct. But recognizing that that adjunct takes time from your team members, and so they either have to have buy-in that they also care about collecting this for a reason, and not always collecting data for papers and for research, but to improve patient care, you know, or even the knowledge. How many patients are we intubating? And they probably know that already. But, you know, I mean, some of that is just valuable information for your team. That was why one of the pieces that I like is this heat map that shows you, do you want to know times of the month they're arriving? Do you want to know days of the week? Do you want to know hours of the day? And most people who work ED are aware it's generally in the evening. when they all like to show up because they've been hurting themselves all day and now they're out having a good time. So collecting data is challenging everywhere. Even when I worked in the US, I worked at a level 1 trauma center. Part of how you would collect, because one of the biggest things is who arrives on time. You know, like with recess, they can have the timer of who, or for RRTs, who shows up when. For trauma, it's challenging. You're walking into a room, especially if it's a tier 1 trauma, there's a lot going on. Could be CPR, they're getting ready to intubate. You have someone else looking, what do we have going on? Do we need to stabilize a neck? Do we need to stabilize a leg? So what we had back home was you would badge in when you walked into the room. There is a cost associated with that though. Then you've got to put a badge reader on every door. And people have to remember to badge in. Or if they forgot their badge and they have a guest badge, they can't badge in. But then not only badging in, you've got to be able to pull that data from badge readers and associate it with a chart. So everywhere I've worked, I don't know anything perfect. The closest I've seen, there was one trauma center I worked at where they had one nurse and her sole job was documenting. She didn't help with anything, but the way it was lined up, she knew who was on staff for her day. She could click the button, and when they walked into the room, she would just drag them because it populated who was there, and she dragged their name just over onto the chart. She didn't have to type or collect anything, or he, but we know as a she. She would just drag and drop anyone when they showed up, and as they did procedures, you have your standard procedures. So, sorry.
Any other questions? So I've got one just regards mechanism of injury.
Yes.
And it's a big one.
Yes.
And I think it's very important that this is highlighted in anything going forward and how you incorporate that. Because you can have a simple open fracture with a little wound and he might have just fallen off a step. But if you don't know he was in an ATV down in Sidra at 80 miles an hour, it completely changes the outcomes. So how do you think we can kind of push that forward? And secondly, it was just leading on to other data capture with regards to what Mitch was saying. What do we want to capture? Is it only T1, T2? Majority of these orthopedic cases essentially may even fall out of T2 categories. Max fact cases, a lot of hand injuries. You might have a carpal dislocation, which is a significant injury. Because it's ambulatory, he's gone home, it's not captured.
Yeah.
So maybe in a separate forum, we look at these type of kind of scenarios where we look at that data as well.
Yeah. I was hoping you had an answer. I have a little bit. I mean, and part of it unfortunately involves creating things where you can select. The EMS does have a little bit of that that's pre-selected in theirs. When you're at Hamad, their HMC EMS records are synced with their Cerner, so it's actually part of it, so they can pull data from that. They still do it all manually because of security reasons. They haven't had approval to do any big data dumps. But if we could get cooperation with EMS in order to link our Cerner with their Cerner, we maybe could get some of that. And part of that is picking our biggest ones and having an other. And that's really hard for providers to have other as an option because there's so many choices. But if you start listing, 20 things, then you have a nurse or provider going, I can't find it, other. Exactly. And if you've got like 4 tight ones and then your others, your 4 tight ones are going to catch most of it, which is going to be falls, motor vehicle accidents, auto pedestrian or auto bike, and thuds, which is when something falls on them. So.
I was just going to add, so we've got the list of serious mechanisms, as Stephanie says, and we've got the tier 1 and tier 2. We have a myriad of other presentations in the ED. As Noora said, from diagnosis, not always a reliable way. From presenting complaint, not reliable. You can categorize the presenting complaint, but again, that's asking a poor nurse to go through a list and try and put a patient in a category when they're first meeting them. When the mechanism isn't clear, when the diagnosis isn't clear, and they're presenting with just a hand injury. The word in Arabic for hand is the same as arm. So you can see the complexity. So trying to build consistency is the most important thing, and trying to get consistency and good data for the dashboards is where we're heading, and it's taking a while. But we do have the information available. It's just the effort to validate the way it currently is presented is too much. So we just need to work on a better way, but it's all there.
Yeah, and that's part of why for major trauma, we're working on multi-prongs coming at it. We're looking at the nursing button and quick triage, but again, that misses some power forms and then a consult order. And that way we can try and catch it from lots of different directions and not leave it with one service or one specialty that's their job to let the rest of us know.
So from opening, we've had a way of categorizing whether a patient comes with a medical injury or surgical problem to the ED, which is something I inherited from England. We've never really used it, but it's there. So we absolutely can work out who's coming with what. But my question to you guys as an ED doctor is, what's the purpose? Because not all of the hand injuries are going to Mitch, not all of the nose injuries are going to Mitch, not all of the arm injuries are going to orthopedics. So we need to just really think about our purpose as well. Yeah. Thank you.
Yeah. And part of that could be looking at if you've clicked medical or if you've clicked injury, and then looking at the ESI, which is but we haven't done that, but I mean, you have it, but yeah. So I mean, those are different ways that you can look at it. There's lots of tools and there may not be one button, but you may have to build something that's a combination. ESI is the Emergency Severity Index. I don't love it for peds. I know everybody in the world uses it, but it was kind of built for adults, and so it's based on how many procedures you need while you're in-house. So if you come in and you've got an ear infection and you're probably going to go home, you're going to be a 5. Lisa may fix it some, but it increases as you need things.
Yeah, ESI 1 and 2 are the most severe, so ESI 1 is your tier 1 traumas and stuff like that, and usually anybody who goes to resus. But the 3, 4, and 5, as you say, is based on the number of resources rather than actual injury severity, but they kind of overlap. So the issue there is we're capturing the resus patients with the trauma here because of the tier 1s and tier 2s, but what we're not capturing is the femur fracture that happens to come into the treatment area, which is still one of Stephanie's, we need to feed them in. So the ISS is the injury severity scores, all that kind of stuff also needs to feed in.
Noora has lots of questions for someone who worked with me on this. No, it's just good.
I tried very hard to stay away from this, but no. Mr. Jawad, so how I would like to see as an addition to this dashboard or tableau dashboard is if we have a KPI, if we have a threshold, let's say for, I don't know.
Trauma tertiary surveys is one that we've got.
Yes,
that we can identify.
Something both continuous and a categorical yes or no sort of situation. For a continuous, if I have a number, a threshold, above which I would like something to be highlighted in red, below which it's green. Is that something doable for Tableau? Same thing for categorical yes or no?
Yes, Dr. Noora. So like you said, all the categorization is very much possible on Tableau. It's just getting the rules defined and send over to me, and then I'll get it done on the dashboard.
So the one that we've got that we're working on with the blood products is with the tertiary surveys. So that does only apply to admitted patients. So if they're admitted, they're supposed to get a tertiary survey, usually within 24 hours. If they're intubated, it sometimes takes us longer to be able to go get a good look at the patients. And so if they're one of our patients, if they're admitted, then did we put the tertiary survey? And so then the minimum, I don't like to say, but for the American standard that for the Academy of Surgeon is 80%. I had told my team 85%, so we're gonna all pretend I said 85%, but the minimum is 80%, but I do push them for 85% on that. And like I said, the biggest KPI is arrival time for surgeons, for emergency docs, for radiology, for the rad techs, things like that, and that's the hardest piece to capture. So.
Any other questions? Thanks very much.
I can go back to the cowboy pictures if you guys like them best.
Well done.
So, and Jawad knew the body region, if you could just click on what was injured, was my favorite thing I wanted, but right now we can't do that. I have some ideas I'm going to run past him next time I meet with him, so. Thank you. Sorry, I'll let you fast forward me to the end.
Thank you to the panel and to Ms. Stephanie for that amazing insight. Now we'll be moving to our quality presentations. And to introduce the presenter, let me introduce your moderator, Senior Attending Surgeon of Orthopedics and Quality Lead for the Surgery Department, Dr. Abdul Salam Hijazi.
Good morning, everybody. So thank you very much for hanging with us. It's the last session for the morning, and we are between you and the lunch, I think. So today, I'm glad to be here and to present my co-judges. Please join us welcoming Dr. Elisa, who is a senior attending from emergency department, and she is the lead for the quality in the emergency. Please, Dr. Elisa, come and join me here for the session. Also, I would like to invite Mr. Rami, who is an master holding quality guy, but unfortunately now he's working more with the education. He's a nurse educator. Please, Rami, come and join us for the next session. This session will be, again, like the research session, 5 presentations. Each will take 8 minutes and 4 minutes for questions. We have the timing in front of the presenters, and we would like to finish at the time, as I said. Otherwise, we'll be eating cold food. So it's up to you. Yeah, Dr. Yaser El Hout, please.
Good morning, still. Today I'm gonna talk about a model that we devised. We name it catheter in catheter. It's a low fidelity model, and it's intended to teach intermittent catheterization for children with neurogenic bladder. Unfortunately, I still declare no financial disclosures. So clean intermittent catheterization, or we call it CIC, is a vital procedure that is frequently necessary in children with neurogenic bladder to ensure bladder emptying and safeguarding the upper tracts. And actually, it can be challenging to convince children or their parents to initiate CIC due to anticipated apprehension and perceived difficulty. And actually, there's lots of articles in the literature that stress on the importance of the family's adaptation and embracement of the CIC and anxiety levels in caregivers that can be associated. And actually, if you look into the European guidelines for nurses, they actually, in their guidelines, state that it is important to look into the psychological, emotional, and practical needs of the patient and family. And when teaching is needed, an instructional doll or a mannequin should be present. And then if you look into those dolls available, if you go on an online search, you find that there are lots of models available. Some of them are fancy, but they're not functional, and actually they're very expensive. So for that, we describe an innovative and a functional and cheap model for teaching and practicing CIC for children with neurogenic bladder. It is a low fidelity model, meaning it's a simple design, and it should simulate reality and functionality. It's a do-it-yourself. You find all the needed material in your clinic or in a stationery or grocery stores, and it costs under 20 riyals, actually. So basically, we needed a bladder, and the bladder was a ketchup bottle. So after you empty the ketchup on your French fries and you have an empty bladder, it's actually good capacity like a bladder, and it's stiff like a neurogenic bladder. But the good thing is that it has a valve mechanism and actually is continent. And then for the urethra, we used a 22 French suction tube that snugly fits with a 16 French catheter. And for the external genitalia, so you can see here how they can actually catheterize, and hence the catheter in catheter concept. And then for the external genitalia, we use the tip of a urine cup, and we can use it both sides, one side for a male and the other side for a female. And for the female, for kicks, we can actually put a blind ending vagina so that when you catheterize, you know to go into the right hole. And then we assemble all that as seen in the demonstration on the stage. And this is basically our model. We use a styrofoam cupboard for assembly. And we hang the bladder on a kebab skewer, wooden skewer. And there you go. And then you have an artistic interface for it. And this is actually the catheterization going. And you can see that urine comes easily when you're inside the bladder. And when you remove it, it's completely continent. And actually, it's superior to any model because it's actually functional. We presented that in the ESPU last year. So we basically tested and exhibited this model in the World Spina Bifida Day. We used it on 20 children who practiced it and loved it. And hence, we considered this model to be cheap, easy to assemble, and readily made available. And it would encourage, engage, ice break, teach, and allow practice of CIC for children, caregivers, and involve healthcare professionals whenever it's clinically anticipated or required. Now, going from there, we looked into the forefront of healthcare, our nurses at Sidra, because we often entrust them to perform and teach CIC. So are they actually up to it? So we, in the World Nurses Day, we surveyed 37 of our nurses. 86% were females with a median age of 37 years, with a good experience, 14 years of experience, and they come from a multinational background. And 16% never had any formal teaching of catheterization, and 27% of them had very little or no knowledge at all of what urological conditions are needed to do CIC for. 35% never practiced on a model, and then 81% of them never did a CIC for more than 1 year ago or not at all. Only 5% of our nurses have done CIC 1 month or less. And when you ask them about what are the skill sets needed to perform CIC, 19% of them consider the skill set to be difficult or very difficult, and 14% of them are not confident at all to perform CIC. When asking them about their confidence in teaching CIC, 32% can teach it to a child, 41% can teach it to a parent, and 49% can teach it to a nurse. And then when asked about if they think that having a model useful for teaching CIC, they said yes, 86%, and 84% are willing actually to practice on that model. So hence, we identified a learning and training gap, and we have our model. So our future direction to do a prospective randomized study to validate the model underway. We have 2 arms. We have already recruited 18 nurses that will be randomized to arm 1, where we'll have the classical pathway of teaching, and arm 2 will have the classical pathway, plus the training of this novel model. And then both of them will be assessed by blinded assessors who will see the value of that model in imparting skills in doing CIC. And hopefully the results will be presented to you in the coming SARD. Thank you very much.
Amazing model, Yaser, great talk. And I think the key is it's very simple and it can be reproduced. My only comment was, did you look at the size of the length of the urethra? Because you're trying to practice with. Does that have to, because it looked like it's quite long.
Yeah. So basically, when I was putting the model together, this is actually the product of lots of trials and errors. And if you want it to be very anatomical on a child urethra, it's very short that technically it's difficult to assemble it in a way. So if you want to be anatomically precise, this is longer than the urethra, but I was looking into the convenience of doing a successful catheterization where the success is getting inside the container, which is the bladder, and getting urine the moment you get into it.
Can I ask if you see in the future there'll be a female and a male version? Or?
Yeah, so basically this is the male version that you see.
Just one more question. We always think when we are teaching a skill to someone, what could go wrong? And that's something to tell them, to recognize, and to learn. So urethral injury or incomplete emptying, how are these depicted in the model, and how do they learn that little bit of piece?
Yeah. So actually, one of the problems to start the CIC is the perceived difficulty of doing it. So this model will not simulate injuries, obviously, but it will ice break the mental burden of starting it. So when you start it on an inanimate model, the caregiver or the patient will not be afraid of a complication that will happen, and he will be more bold or more forward to start it. And that's exactly what it's intended to be. The complications probably will be part of the didactic or the teaching part, the theoretical part. And it's part of our nurses' teaching. We're doing a didactic session to troubleshoot all those perceived complications. It's not the perfect model, but it's the good thing is it surpasses the available models in the sense that you go inside the bladder and you get urine immediately, which is no other model, even the most expensive ones can offer that.
Any more questions? Thank you very much, Dr. Yaser. Yeah. Can we have the next presenter, please?
Hello, everyone. Actually, today I'm going to present quite a project we have done in OPC regarding the Code Blue Mac Code training. To ensure the safety of patients and medical team during a Code Blue event, we believe appropriate training should be implemented. And currently, majority of the staff, they have limited exposure of BLS training, which is required for renewal for every 2 years. And especially in OPC, because of the limited exposure actually for the live scenarios, which is make it more crucial to have appropriate training about Mac Code. This project aimed to evaluate and provide the training needed to maintain competency of OPC nurses during a Code Blue. Ultimately, patients will receive the vital intervention during these events. Our objectives: assess baseline competency, implement Mac Code simulation, target training and education, evaluate training effectiveness, monitor and improve attendance, measure post-education improvement, implement continuous feedback and education, and sustain competency improvement. To have a baseline data, we have done a BLS quiz to gather baseline data about the staff knowledge regarding resuscitation and life emergencies. And based on this quiz, we have the data that shows our average score. It was 61.8%, which is an area for improvement, with a minimal score of 28 and maximum score of 92. We put an action plan. We start with analyzing the situation. As we mentioned, we found an area of improvement with our BLS quiz, which is an 61.8%. New staff onboarding, because everyone is coming from different background. We don't have the standard knowledge about the station. And during our observation, during the real scenarios in OPC, we noticed that our staff were really struggling when it comes to deal with an AED and navigating the code card and the code card contents. So one of our improvement plans, we start with the structure of the code team. We plan to schedule with a target time, and we create safety messages to cover all aspects of resuscitation. And those messages were sent every week, one message, and to discuss on a daily basis and all over OPC and their huddles. After Mac Code, we send a feedback survey for the staff to get feedback about the performance of the code team. And actually, the survey shows positive results with more than 75%. They strongly agree with our performance of the Mac Code team, while 15% agree, which imposes positive feedback. And to make sure we're providing effective education and training, we had to use a standard debriefing tool, which is a Rust model. Educational support, actually, from our Mac Code training, we identified areas where they really need more support and education. Then we conducted 3 additional education sessions to cover four services. As we mentioned, we identified there was a gap with the familiarization with an AED and the code card. That's why we tasked our nurses team to do a series of education about the AED and defibrillator use and how to navigate the code card, and they have done a great job on that. After six months of evaluation of education and training, we reevaluate the staff, the 35 staff that we already tested, and we have a big jump in improvement from 61.8 to 91.1. After that, we launched a survey to gather feedback from staff regarding their experience with the mock code drills. The aim was to understand their perspective on the effectiveness of this simulation and to identify any challenges they face during this process. The survey also provided an opportunity for staff to voice their concern and offer suggestions for enhanced training. This is some data from the survey that we launched. In the aspect of staff confidence in managing Code Blue, actually the data shows that staff displayed 66% confident to some extent and 18% very confident. And in the aspect of mock code effectiveness, 45.8 responded as it was very effective, while the same percentage, 45.8%, considered it effective. Also, in the aspect of subjective feedback and challenges faced by staff during Code Blue, during mock code, the analysis of both diagrams identified that enhancing communication and role clarity, it was an area for improvement. Actually, the survey data indicates a need for more further mock codes, as well as greater support in enhancing communication and coordination during Code Blue event. Our future plan, this was done in 2024. The future plan for 2025, we start from January itself to do more frequent mock codes. We're aiming to do at least 3 mock codes each month, and also to be re-evaluated after 6 months. We're aiming in January, and to place greater emphasis on the briefing sessions to stress the importance of a clear communication and lower clarity during Code Blue. And also one more thing, we're going to do it in the future. The next stage 2, we're going to involve our medical team also, like doctors, to be involved in our mock codes. Thank you.
Thank you very much, Raydan. First questions from the audience, then I will direct the...
Just a question to clarify. The nurses in the inclusion that you surveyed, were they from a certain section, like let's say ED, or were they from all over? And was that accounted for in your analysis?
Actually, it was, the project was targeting only OPC nurses. So it was all OPC, not only surgical OPC, surgical services. So it covered all OPC nurses only, yeah.
Yes, Rami.
Great achievement, Raydan and the team. My question is, do you have any data to correlate this enhancement in mock code training with the real code or the code results? Like, I mean, this training, does it improve any outcomes in the codes when there is real code in outpatient, for example?
Okay.
Like you compare the previous data when there is lower mock code training with post.
Yes, thank you for the question. Actually, as we all agree that skills you don't use, you're gonna lose. So eventually, because this project started because we have limited exposure to live scenarios. Actually, that's one of the challenges that we have. We have very limited exposure to real emergency and real Code Blues in outpatients. And that's why it's very limited to have to assess how it improved. But yes, it's one of our plans to see how it's gonna go live, how we're gonna improve in real scenarios in the future. But now, for the meantime, we're basing our assessment based on our tests we are doing, with our surveys we are sending, and based on our BLS quiz that we already done. Mind you, in the beginning, the baseline data, we do it as a one-to-one evaluation to make sure we're collecting a very accurate data and about the staff knowledge.
Yeah, I think the answer will come maybe if we do the same project with the ED nurses, because I think as educator as well, I'm not sure how much we are targeting the ED staff with the BLS courses and education, and maybe you can collaborate later on with Lisa and do some more training there, and you see the real impact of this education for the nurses with the hotspots like emergency. Any question or comments, Lisa?
Thank you. Yeah, on that topic, I was wondering there might be some kind of debrief scoring tool that an objective person could put in after a real event that could show the confidence of the people involved. I don't know, but we could have a look for something like that.
Sure.
But it's lovely to see that you're going to involve the medics next time, because you'll get your team very comfortable within their role, and then you'll introduce some guy who's happening to do a clinic who is used to running things a very different way. So it'll be lovely to see how your team adapts around a new member coming. It'll be good.
Absolutely. Actually, because when it comes to outpatient, there's people, they think that they are away from this kind of dealing with emergency people, with real deteriorating people. However, if the patient deteriorates in your clinic, you have to deal with this patient until the COD team arrive. So yes, sure.
Any more questions? Thank you very much, Raydan.
Thank you.
Next presenter, please.
Good morning, everyone. So my name is Gayathri Vijesh. I am one of the inpatient pediatric surgical nurse manager. So my research is one of those areas you cannot find much review of literature. As you see in the floor, nurses are always available to take care of your little adult 24/7. But sometimes they miss to take care of themselves. So I researched to find a better solution to that problem. So before moving to the problem statement, I do not have any financial disclosure. So my problem statement is enhancing nurses' well-being and break management in healthcare through the implementation of a break board system. So in the next 8 minutes, we are going to discuss about the purpose of the study, background, aim and objectives, research methodology, findings, results, and conclusions. So the purpose of the study. 5A is one of the inpatient unit where we have a combination of complex surgical cases and neurology cases. As you know, due to the criticality of the patient, most of our patients we need very close observation, and some of our patients needs a 1:2 ratio, sometimes 1:1. Sometimes for some specialized procedure, we need 2:1 even. And sometimes we are taking a patient, we're supposed to go to ICU, but we are taking them. And sometimes we are doing a very high-cost procedures, and sometimes some of our patients are ceasing every minute and every seconds. So these all contributed our nurses to take the break properly and as per policy. So how I reached to this study? So last year, we have conducted an employee satisfaction survey in our unit, and one of the issues my nurses has brought to me is they are unable to take a proper break management. Either they are interrupted in many ways by Vocera, call bells, or they are not comfortable to leave their high acuity patient to take a proper breaks. Or sometimes our unit is one of the unit, we can find staff assist, that is call bells, lot of time, again due to the nature of our patient. So there was, when we are looking for the review of literature, there was 2 studies conducted, as I said before. It was a very limited area we can find review of literature. In one study, it shows that insufficient breaks, which leads to nurse burnout, and another study shows that regular breaks reduce the burnout and improve well-being. These findings really highlight the importance of addressing break-related issues to improve nurse satisfaction and patient care. The aim of this project was to enhance nurse well-being and job satisfaction by ensuring proper uninterrupted breaks during shift, and the implementation of a break board aims to optimize break scheduling, reduce interruption, and promote regular rest periods, helping to alleviate mental and physical fatigue. In the methodology, this research was used one group pre-test, post-test experimental design. So in the pre-test, there was a series of questions was given to the nurses in order to assess their knowledge, awareness, and satisfaction. It was an online survey which composed of certain series of questions. This is most of the questions I gathered from their comments. We do have a Q&A session in our unit, so most of the time they are raising their concerns anonymously to me. So from their concerns, we created a group of questionnaires, and which was given to the nurses to a period of 2 weeks electronically. And in the intervention period, there was implemented a break board, which is a beautiful, simple, visual management board, which is placed in our CNL office. And with the help of the unit clerks, we are keeping our nurses' name in each shift. And each time when the nurses will finish their breaks, they will put a little icons which represent the foods, which really help my CNLs to provide support for those nurses who are really in need, or identify which nurses didn't have a proper break that day. And after 2-month trial period of intervention, we have done a post-test, which was mainly to evaluate the changes in nurses' break practices, awareness, and satisfaction. Again, these questions were open for 2 weeks. It was electronically. In the beginning, there was a plan to do the survey anonymously, but later, my team is a diversity of having lot of senior staffs and lot of new joiners, and their problems will be different. So we have conducted an anonymous survey, which helped me to really understood what is their actual problem, because sometimes some new joiners are not allowed to leave the patient. Sometimes they have an issue with time management. Sometimes they are thinking, remaining everyone is busy, how I will go without leaving the team. So this really helped to identify the problem very individually. As you can see in the table, the result was just amazing. Surprisingly, a huge amount of nurses understood the importance of taking the breaks. And we can see there is also increase in the frequency of taking the breaks. And another surprise or the bonus point of this study was there is an increased support of the supervisors, that is my CNLs and team leads. So they understood also how important it is to support the nurses for taking the proper breaks. While we are doing the analysis, we can see that there was a substantial improvement across several areas. Staffs are taking the breaks more frequently, and also 93% of the nurses expressed their satisfaction with the break management system. By conclusion, I can see in 5 ways, there was a substantial shift in the cultural shift in the workplace, and making the break as a prioritized aspects. The system seems to have alleviated some of the workload and staffing challenge by creating a more structured environment for break taking. This shift not only enhances staff health, but can also positively affect patient care. I just wanted to conclude my study by saying 2 lines. When you will travel in the aeroplane, what is the first announcement you are hearing? You have to put your oxygen mask before you are helping anyone. Nurses' break is that much important, because whenever you are in a need, your nurses are always away, just a call bell. Thank you.
Thank you very much, Gaia. So yeah, I would start with from where you finished your talk, that always as a healthcare providers, we always do our projects, researches, focusing on our patients, and nobody's looking, or very less number of us looking after ourselves. And the rule number 1 is you have to look after yourself so you can provide the best of yourself to your patients. I can see that there is a queue in the here, yeah? Santiago and Dr. Noora. Okay. She's sitting behind you. Yeah, go ahead, please.
Thank you so much for sharing this. 2 things that I would like, if it's possible, to have maybe the next year. 1, impact on patient satisfaction. 2, can we see a picture of this board? Because I will be really curious to see how it's done. Because I couldn't. No, the board. Oh, board. What you have in the word.
Yeah, I didn't.
No, that will be interesting to know. So for us to learn as well as physicians, yeah, how you are doing. And 3rd thing, are you expanding to other areas?
So that is my another vision. I am really waiting to see any of the nurse manager is interested to adopt this one in their unit, because when I talk to multiple leaders in different parts of the world, my friends, this is one of the global problems. Nurses break because they always feel guilty to take the breaks before taking care of, it's not about before taking care of the patient, especially when you are doing a 12-hour shift. It's not easy. But they are not realizing how much it is impact on their burnout. So I am really looking forward, some of the nurse manager will approach me for this model. And the picture of the board, sorry, I didn't put it, but it is a simple visual management board, which is created very interestingly with the help of one of my nurses, which is having a little picture of pizza, juice, and each time when they will go for the break, they will come up and they will put their little notes on that one.
Thank you very much, Gayathri. Wanted to ask, and this is for us to also get an idea, could this be implemented elsewhere? Is there a guideline for an exact number of breaks per X hour shift? Let's say a 12-hour shift, you have to take 2 breaks, and they're spaced in between. Is there such a guideline? And then comment number 2, in addition to looking at patient satisfaction as an outcome, I would also extend that to patient outcome, full stop. Were there better, less morbidities, more morbidities, better detected, faster detected when the nurses have had more breaks and are rested and are able to pick up issues, let's say?
So the first question is that, yes, we do have a very beautiful policy which says that how many breaks nurses needs to take and how many hours in a 12-hour shift, in an 8-hour shift. So it is there, it is crafted already. Only the problem is that because of multiple reasons, no one is following that one. And the second question?
It's more of a comment for next year if we are going to see the results of this, to add, in addition to nursing satisfaction, patient satisfaction, and patient outcomes.
Yeah, sure. That will be something we can look for in the future, how it is affecting the patient's satisfaction.
I just want to ask you, did you consider the other healthcare providers in your research, or are you thinking of considering that? Referring to the operating room here, I have incidents where a resident who fainted, okay, and when I have to catch. So I think this is like an eye-opener for, I'd like to looking at what policy says about also other healthcare providers and how they take care of that. And I think also something that to think about from the perspective of other healthcare. It should be comprehensive. It should be, I think, you know, holistic for all employees. We can expand that. Just a comment. Thank you. Yeah.
When we done in the research, one of the findings was surprised me as well, which is increase the awareness of the among the nurses, the importance of taking the breaks. That was something I never expected. So that was one of the bonus point I received after doing the research.
Last question.
Thank you, yeah. I was just going to echo exactly that. If you'd like to roll it out to the ED physicians, I think we'd be really grateful. But the specific outcomes, as Dr. Noora mentioned, in terms of also what the nurses actually feel better about, are they more able to then face their next task? I think you mentioned it, but hopefully there'll be some comments the next time that you do it that are more specific. Thank you.
My question, are you going to continue this break board on the long run to see how it will be affected over 1 year, for example? Because you know the census or the workload, it will change from month to another. So to have your exact data over 1 year. So are you going to continue with the board or just 2 months and you are satisfied?
No, actually the board is still, we are continuing, but the major challenge we are facing now, sometimes they are forgetting to put the little icon in the CNL office. We are still encouraging to do that one, but what I noticed that there is an increase. They are really taking the break now. Of course, it's not 100% because of the volume of our patient, but it has been improved a lot. In order to solve that problem, actually, I really wanted that board in my tea break room, but the space is very small, so it is not happening. So we are looking for something, how we can move that board from CNL room to tea break room, which is really improve more outcomes.
Thank you very much, Gaia, and thank you.
We will continue with the next presenter, please. We are behind the schedule now.
Hello, hi, good afternoon. My name is Caroline Kansiray. I'm a CNL in 5A, Neuroscience and Surgery Unit. And I'm here to present my project to assess the impact of a nursing-based competency focused on orthopedic devices on improving nurses' deliverance of care to prevent pressure injuries. I do not have any financial or anything to disclose. So my project aimed to evaluate the nurse's knowledge of orthopedic devices pre and post a nursing-based competency. The goal is to assess the effectiveness of the competency and its impact on improving nursing care to prevent pressure injuries and increase the nurse's knowledge in pediatric patients within our 5A orthopedic surgical unit. The aim and objectives, the nurses will demonstrate an improvement in their knowledge of orthopedic devices and how to care for children with these devices as we measure them by pre- and post-test assessments. We will present the findings highlighting improvements in nurses' knowledge and after the completion of the orthopedic competency. Ensuring all nursing staff are proficient in managing orthopedic devices, thereby safeguarding the skin integrity of our pediatric patients. The methodology for the project was a pre- and post nursing-based competency, which was completed by staff. Staff members were asked to complete pre- and post assessments on 5 key areas: overall knowledge of orthopedic devices, knowledge of prevention techniques and frequency of pressure release of the devices, understanding of potential complications, recognition of signs and symptoms of compartment syndrome. Our analysis of the results shows there was an increase in all areas, the biggest increase in the knowledge, and then in prevention as well, how often that we release the pressure, complication knowledge, and signs and symptoms of compartment syndrome. The data shows that there was a significant improvement in the knowledge post-assessment of our competency. Comparing the nurses' knowledges pre and post revealed that there was a big improvement. And one of the most significant results is potential for better patient outcomes. In summary, the results showed a significant improvement. The analysis of the project highlights the importance of regular competencies, which we do yearly, in maintaining high standards. It also emphasised the needs to continuous evaluation and improvement of training programs to ensure they meet evolving needs of staff and for our patients. And that is all. Thank you.
Thank you, Caroline. Questions or comments from the audience? Yeah, please, Lisa.
Thank you, Caroline. Was this in response to some particular patient care issues that you'd identified, or?
We did previously. We did previously have some patients that had pressure injuries from the orthopedic devices. So we put the competency into our yearly competencies that we do. Usually we do 3 to 4 a year on 5A, and because it became a lot of our children are very vulnerable. Their skin is very fragile. They're having, abductive pillows inserted, they've knee immobilizers, that if the nurses weren't releasing the pressure or we weren't opening the abduction pillows, there was previous instances of pressure injuries. So with the a lot of new staff coming in and with the knowledge, it was yearly, yeah.
Have you been able to show a decrease in some of those events?
Yeah, like we haven't had any, we did this competency in May. It went from May up until the beginning of August, and we haven't had any pressure injuries in orthopedic devices since then, which is good.
Yep. Any other questions or comments? Yeah, thank you very much, Caroline.
Thank you.
Thank you. Yeah, last but not least, Mr. Peter, you're going to present. quality project. Yes.
Hello, good morning. My name is Peter, Senior for Peri-Op Surgery, OPC. I'm here to talk about our abstract, Standardizing Tracheostomy Care, a multidisciplinary initiative for improved patient outcomes. I'm presenting this on behalf of MDT. Our MDT comprised of Larkin, our NP nurse practitioner, David, our nursing director, a few managers, RTs, SPD, IPAC, CNFs, educators, a lot of them. So I'm presenting on behalf of them. To start with, I'm going to go ahead with our problem statement. So our MDT was formed early last year, 2024, to address variations in tracheostomy care practices across Sidra, as highlighted through DATEX incidents and expert observations as well, and to improve patient outcomes through evidence-based protocols and comprehensive training programs. As you can see, these pictures could have been avoided if proper tracheostomy care were provided. Our main objective is to improve patient outcomes by standardizing tracheostomy care, and this includes developing evidence-based protocols for tracheostomy. So we're primarily utilizing one of the sources, which is the UK National Tracheostomy Safety Project. The other one is creating training programs for healthcare providers, and lastly, implementing these protocols and programs across Sidra. And this is a quality improvement because we have variations which we actually want to address by having it standardized. So the gap between our current state to our expected state is the quality improvement that we're actually going to be going over, which I'll talk about in a bit. When we first started, we actually pulled out data from DATEX, to find out what these variations are. So we pulled out a year of data from Feb 2023 to Feb 2024. And as you can see, there's a mix of issues, such as, for example, there's one incident about RT staying in IR or DSU as staff feel uncomfortable. There's also lack of education that staff feel. Trach management, emergency bag, it was incomplete. So this was about having the emergency bag, but sometimes it's missing or sometimes it is incomplete. The other one is talking about emergency head-of-the-bed signs, which is this one over here. And then the next one is familiarity with equipments and so on. So this is the list of issues that we have identified. So these are the common themes that have been identified through a review of DATEX, okay? I've broken it down farther to make it more sense, in terms of, okay, so what are the top issues actually that we can actually address in terms of having a baseline and then comparing it to our result post whatever we're doing, right? So to give you an example, these are the common tracheostomy issues that we've identified. So for example, our baseline for skin integrity, there were 3 events. Patient care management, 11. So patient care management, this is about misuse of tracheostomy cuffs, incorrect suctioning, missing or incomplete emergency bags. And then for medical equipment issues, this is about having inappropriate trach sizing, non-MRI compatible trachs, and then also accidental decannulation, we had 4, and then supply chain issues, 5. And again, I'm going to use this as my baseline later on to depict what the improvement is. Going back to our fishbone, so we actually looked at the fishbone again. This is to find out, okay, so now we do have a list of causes. What are we going to address, right? So our MDT then identified that this area over here, we can address through staff education. Why did we choose it? Because we feel that we have the most control over them and that it actually has the most impact as well. And then second one is through family education. So we believe that once we actually do staff education, then we can also educate our parents, our families as well. The other issues over here, we'll also address them as well. So this is about supply chain issues, non-MRI compatible trachs. We've also done initiatives to address those, because if we just forget about them, then data is still going to happen around these issues. So we actually have done initiatives to address all of these. Talking about our work group initiatives, so we actually started with reviewing our tracheostomy guideline, and it was done. It was published late last year. There's a big certain changes which is still ongoing. Our educators have reviewed our Lippincott e-learning procedures. Initially, it was a mix of adult-based content, and now it's more geared towards pediatric, and it's following our current tracheostomy guideline as well. Next one here, we do have emergency bags now. Our old bags, it was the manufacturer of that bag. They actually started producing them. So we procured a new emergency bag, and it's now in the circulation. Next one, we have standardized our workflow for sterilization, which has been a big help, because one of the issues when we pulled out DATEX is about supply chain issues, right? But when we started our workflow on reusing trachea tubes, it actually decreased, which I'm going to show you later, and then the cost saving as well that we've also done. Next one, we've standardized head-of-the-bed signages. So these are your head-of-the-bed signages on the back of your patient's bed. It actually has gone through multiple cycles of PDSAs, and now we're using the final version of it. Next one is your daily checklist. So this is your checklist for a nurse who's looking after trachea patients. So for example, if you're looking after this patient, you would have a list of items that you need at the bedside. So for example, is there suction working? Do you have a rolled towel or blanket at the foot of the bed? In case of emergencies, you can use it to hyperextend your neck, and so on. Next one, we do have emergency bag checklist as well. We do have passports, standardized passports. So think of your passports. I only have 7 minutes left. Sorry, 1 minute. I have standardized passports. I have workflows, tracheal dilators. These are now completed, and then we also have resources, workshops that's still ongoing. So this is a major thing that this is one of the initiatives that we're actually doing, is conducting monthly tracheostomy workshop. So far, we've trained 180 staff from identified areas. We are still looking to train 200 plus more. And we also do get regular attendance from medical residents as well. So results, as you can see, my baseline from Feb 2023 to Feb 2024, after formation of MDT, which is over here, you can see a gradual decrease of DATEX incidents related to tracheostomy, because once communication is started, communication started as well, or shared during huddles, then you can see the gradual decline. Our first workshop for first cohort of nurses started in August. Interestingly, you can see spikes in November and December. When I looked into it, these can be linked to nurses who actually had not attended tracheostomy workshop. And going back to our baseline, post-MDT, you can see the results. So as you can see a difference in terms of skin integrity, post-MDT from 3 down to 1, patient care management from 11 to 10, and so on. And a complete resolution of supply chain issues as well. This is just confidence level, pre-workshop and post-workshop. Pre-workshop confidence level. It's a mix of not so confident, neutral, and confident, but post-workshop, you can see that all of them actually felt confident to look after trachea patients.
Peter, please, can you conclude?
Yes. Tracheostomy, MDT, and ENT's proactive approach. So we've seen bleeding rates have actually decreased. Initially, it was one event every 2 to 3 weeks in 2023 and early 2024. Now it is one event every 6 to 8 weeks. Inanimate artery erosion rates have also decreased from 2.3% in 2024, and now it is 0%, and decreased clinic visits as well. Lastly, anticipated economic benefits, so we have efficiency, economic, and others. And just to give you guys an example, the number of sterilized tubes from April of last year until December 2024, in OPC they've done 161, inpatients 34, and soon DSU and complex care are also going to be joining, so this number is going to increase. And in OR, they've actually sterilized 324 tubes, thanks to SPD for providing me these number. And that's a total of 519 tubes. So if, thanks to Mikey from RT Equipment Room, he's saying the average cost of a regular tracheostomy tube can range between 500 to 800 riyals. So if you say if it's 800 riyals times 519, that would be 415,000 Qatar riyal saved. Conclusion, by implementing evidence-based protocols and workshop, tracheostomy work group observed the, really good feedback from our peers, significant decline in daytax incidents and common tracheostomy issues. Lastly, for next phase, we're currently doing with Dr. Lisa, clinical audit projects, because yes, we're doing this, all initiatives, but how does it, relate at the bedside? So we're doing this clinical audit project to further or continue for any improvements, find gaps as well. And there's a discussion about training Al-Maha staff as well. So if you think about it, this is another way for us to actually get more revenue also. And lastly, last but not the least, tracheostomy is actually part of 2025 clinical priority guidelines. That's all. Thank you.
Thank you. Yeah, I can see.
Questions?
This is a great project, Peter. However, I would like to know what's the number of the patient with a trach between February 2023 and 2024, and how many patients among this group they have problem with trach care. And another question, after conducting this workshop for trach care, how you will monitor, what system you will have in place to monitor the compliance or the improved care for this patient afterward?
Exactly. Thanks for that question. I think I've actually presented the data baseline in terms of skin integrity, tracheostomy care management. Under that is under that category, we've actually identified suctioning in terms of dealing with issues. I categorize it under patient care management, patient care. So it's actually, it was one of the slides with the numbers as well. I believe it was from 11 down to 10, from baseline to post-MDT formation. And then in terms of how we're going to be assessing this or, getting the results post-MDT, we're doing this with Dr. Lisa, with clinical audit group, to actually find out gaps, to have continuous improvement, because we cannot just stop now, right? Now that we've done all the initiatives, we just need to actually continue to improve on what we've started.
Do you have data how many patients hospitalized with tracheostomy between February 2023 and 2024, February?
I can pull that data from, we do have a dashboard called Tracheostomy Days. So yes, I can easily pull that data, but right now I don't have it with me.
Okay, thank you.
Any other questions?
Is this sort of data also available on your trach registry? I've heard rumors around that you're starting one, you're working on starting one. That sort of information would be easier to audit if you have it already on the registry, easier to kind of market. Then that's one question. Question two, I saw that you initially used data from Datex to maybe recognize and maybe also monitor and see what's going on. How reliable is that? Were there any Datexes that you thought, okay, I'm going to omit those? We see a lot of Datexes done or used in a different or inappropriate way. How do you address that?
So I'll answer it. I'll answer your question, the second question first. So in terms of the Datex, so we basically came up with top 5 issues, so we can easily track to see for in terms of tracking for improvements, pre and post, it would be easier to track. So this is number one. In terms of the registry, we're not sure how we can incorporate our data into the registry. So this is another thing that we can actually look into. Thank you.
Yes, Raydan.
Thank you, Peter, for the great project. Actually, in ANT, we really appreciate what they're doing because, as you know, we're dealing with the tracheostomy patients as well. Anyhow, but just looking forward, how did you thought how we can maintain competency for those people that you're training? Because I do believe one workshop, it won't sustain competency. As we agree, competency is about continuous education, and not every day you're dealing with a tracheostomy patient. If you teach on stuff today, after 1 month, you're going to forget. So did you thought of training link nurses on their clinics or on their wards to train the rest of the staff to make sure that you have a continuous education training about this particular thing?
Yeah, 2 questions there. So yes, when we started our work group, we actually thought of having to train link nurses, like champions. But we thought of it as we already have so many champions on the unit, right? And then it's just going to be putting a lot of pressure on that champion. So we have identified key areas across the hospital. So areas that actually see patients, trachea patients. So we've identified that out of those areas, 480 in total. I'm not sure. Right, Rowena? 480? Yes, 480 in total. Nurses and other, so we're focusing on nurses now, but medical residents are on board as well. So 480 staff nurses have been identified. So we moved away from just having champions because it would put a lot of pressure on champions, and especially with this airway ABC education. So we'd rather do the teaching on all staff from all those identified areas. And sorry, can you repeat your other question?
If you saw the data after a period of time, you had again a jump in your data, right? So how you think you can maintain this competency for the nurses?
Yes.
Because after your workshop, you find that was a satisfying results, and later on you have a jump result.
Yeah.
So how you can make sure you can maintain competency of the nurses?
Yeah, I think I mentioned it in my presentation that it's actually not due to lack of the reason why there was a jump, because it was due to the staff actually who had not attended the workshop. So that was interesting. But in terms of competency, this is, as MDT actually cannot do it alone. So we are in collaboration with educators. We just had a meeting a couple of weeks ago, Rowena. Yes. They're going to be taking over competency. So yes, you will be hearing more on tracheostomy in terms of competency, in terms of other initiatives as well, especially with Cerner. And yeah, any other questions?
Yeah, my final comment or advice, I think, and what Raydan he mentioned, I think what you have as a group to think about how we keep current this competency with the low census of patient with the trach and Sidra. This is what I mean, because everyone will get the training if they don't have hands-on the patients and they practice this. Whatever you will do, education sessions, simulations, it's still, you can't figure that the outcome of this project, it's met 100%. This is my point.
Exactly, and same as you, I'm also looking forward to hearing from Dr. Sandra and your team to, have this concrete, solid competency. Thank you.
Yeah, I think with this we are concluding the morning session.
Assalamu alaikum, welcome back. My name is Dr. Amina Azza and I will be the MC for the rest of the day. I hope everybody enjoyed their lunch. So our next session will focus on AI. And please welcome once again Dr. Noora Al-Shahwani, who will be the moderator for this session.
I'll be introducing the speakers for this afternoon. So we have Miss Maraeh Angela. I don't think I need to introduce her to anyone. The majority of you, if not all, all know her and want to snatch her from surgery. She's our overqualified research and quality coordinator. She's been with Sidra Medicine for a little over a year, closer to 2 years. She has 5 years experience in clinical research, and her experience spans across various fields from dementia, trauma, AI, and now most recently pediatric research. So, Ms. Maria.
Assalamu alaikum, everyone. Good afternoon. I was tricked by Dr. Noora to do a presentation today. So I started my career in research in 2019, and basically, when I started, the handful of tasks that I received were doing systematic reviews on traumatic brain injury and ovarian cancer. And in 2019, AI did not dominate the public space, so I had to do the systematic reviews with pile upon pile of published studies, with my Excel sheet open on my monitor, my highlighter pen, and a couple of sticky notes, and of course, a handful of chips to Jarir to fill up those sticky notes. So fast forward to 2024, on one morning session with Dr. Noora, we're discussing about the ongoing projects for general surgery, and we stumbled upon the topic of automation and how we can incorporate it in our research work. And now we have dug the rabbit hole to that, and it has led us here today. And we're going to explore what AI is bringing to the table, how it's changing the game, and what we need to keep in mind as we move forward. So I didn't have any financial or any other relevant relationships with commercial interests to disclose. These are my learning objectives. And okay, so we know that AI is making waves across research and academia. It's not just a hype. We can use AI to help us sift through tons of literature, crunch data faster, and even break down barriers between different fields of studies. It's also automating the things or the tasks that we usually are not very fond of, like formatting and citations, and even giving us a hand with writing and editing. So on the screen right now are AI-powered tools that can be used to enhance writing and editing. Please feel free to take a snap of the screen so you can try them for yourself. And these AI tools aren't just your basic grammar checkers. They can suggest stylistic improvements, help you generate content, and generally make the writing process a whole lot smoother. And, okay, so now the big question is, how does AI stack up against us humans? Well, the research is pretty interesting. It turns out that when we try to combine human and AI efforts, it often doesn't work as well as we'd hope. In fact, in this study by Vaccaro et al., the results concluded that human and AI combinations often underperform. And this slide just gives you a visual of that performance comparison. So you can see that while AI can be super speedy, that human and AI collaboration might be slower than the best individual performance. Basically, what we can take away from this is that we need to be really thoughtful about how we're integrating AI into our workflows. So, systematic reviews and artificial intelligence. Show of hands in the room, how many of us are familiar with systematic reviews? How many has done or is doing a systematic review at the moment? 1, 2, 3, 4, 5, all right. So we know that systematic reviews are really important as they are crucial for making sure that our decisions are based on solid evidence. They take a deep dive into existing research, and AI, or at least we hope, AI can be used to make this process way more efficient and robust. AI can assist with a lot of the steps involved in systematic reviews. It can help us find relevant studies faster, extract and synthesize data, detect bias, and even keep our reviews up to date with the latest literature. Again, on the screen are different AI-powered tools that you can use for systematic reviews. So you can see I have grouped it according to different functions. So you have screening and selection. Dr. Karima will be discussing further on Rayhan, intelligent systematic review. For data extraction and synthesis, I believe she will also be discussing further on elicit. And also for risk of bias assessment, we have robot reviewer. So risk of bias is all about identifying potential flaws in the studies we include in our reviews. It is essential because it tells us how much confidence we can have in the findings. It also makes our review process more transparent, help us understand differences in study outcomes, and ultimately strengthen the evidence that we're relying on. So there are different types of risk of bias assessment tools. You can take a screenshot or you can scan the QR code. So these different tools are based on the type of studies that you are trying to review. So you have ROB version 2, or the revised Cochrane risk of bias tools for randomized studies. You have Robbins 1s for non-randomized studies, and you have ProBAST, which are used for prediction model studies. Now, as I mentioned in the previous slide, we have risk of bias assessment AI tools. The most commonly used or well-known use is robot reviewer, but a lot of us in academia has now switched to using ChatGPT and Gemini as well in conducting this risk of bias assessments. So these 3 studies were done in 2022 and 2023. The first one, automating risk of bias assessment in systematic reviews. This study compared the use of robot reviewer in conducting risk of bias, and the conclusion of the authors is that they are likely to accept the judgment of robot reviewer, but they believe that human input and human-to-human interaction remains superior, and they, at that moment in 2022, they are not interested to automate the process or the standard procedures in risk of bias. The next study used ChatGPT in using risk of bias assessments, and they found a degree of agreement between AI-generated assessments and the traditional ROB 2.0 judgments. So the next slide, the following slides will focus on our own study that Dr. Noora and I did on using ChatGPT and Gemini in doing risk of bias reviews. So our methodology, we basically conducted the ROB using the Cochrane ROB 2.0 tool for RCTs. Then we used Cohen's kappa to measure how well our raters, raters being ChatGPT, Gemini, and the original authors of each of the studies included in the systematic review. Inclusion criteria-wise, we included studies that had a PRISMA score of at least 22, which is about 80%. We focus on randomized control studies about diabetes mellitus published in 2023 and 2024, and also written in the English language. Exclusion criteria are lower PRISMA scores, as well as cohort case control and other types of studies. We also excluded non-comparative studies and those published in language other than English. So now I will sort of demonstrate what are the prompts that we used. So because ChatGPT was heavily tried among the literature, so we wanted to try Gemini when we did this study. And first we put a very general prompt of what is diabetes mellitus, and then it gave us the result. The next prompt was, what are the interventions for diabetes? Is there any research done for it? And then what are the study designs that are used in diabetes research? And then from the last answer of Gemini, We then ask it, how can randomized control trials be synthesized? And then how can systematic reviews be evaluated for quality? Can we use Prisma to examine systematic reviews? And then we attach the PDF copy of the Prisma checklist and one of the studies included in the systematic review. And we ask Gemini to give us the Prisma score for the paper and to present it in tabular format. And this was the result. So it gave us all the answers and where the specific pages in the PDF that you can find the results. And then moving forward, again, we ask it about what systematic reviews are. And then we ask it to explain further on risk of bias assessment. And now to focus on systematic reviews and diabetes, expand on risk of bias. And then finally, we ask it to use the Cochrane risk of bias tool and elaborate its studies in tabular format. We attach the PDF and the Cochrane tool. And this was the result. So all of the studies were assessed based on all the domains of the Cochrane tool. And when we did the comparison between the Gemini and, so this Brohard, Delort, Dussault, these are the specific studies in the systematic review written by the authors on this side. So you can see that the Gemini and authors have similar agreement for the different domains. And when we did the Cohen's kappa coefficient, which is a measure of inter-rater reliability, the observed kappa was 0.57, which falls under the established guidelines from 0.41 to 0.60, which denotes moderate agreement. And when we tried this with ChatGPT, it also gave us a score of about 0.58, which is just slightly higher than Gemini, again denoting moderate agreement. And now for my last slides. Last slide is basically just a conclusion, or rather the ethical considerations that we need to think about when using AI. We need to make sure that these tools are accurate and reliable, that they don't perpetuate bias, and we're being transparent about how they work, especially about data privacy, fairness, accountability, human oversight, which are all critical considerations. So my main takeaway is that AI has the potential to revolutionize systematic reviews, making them faster and more efficient, but we also need to proceed with caution, being mindful of the limitations and ethical implications. And always the best approach is to combine the power of AI with human expertise to ensure our reviews are rigorous and reliable. So thank you so much.
Thank you very much, Maria, for the talk. We'll keep questions for both talks at the end. Next up is Dr. Maria Shabana from Weill Cornell. A little introduction. She's got a very long CV, so I might not give it enough credit, Dr. Karima. She's an epidemiologist who serves as an assistant professor of clinical population health and science, she currently holds a position in Weill Cornell Medical College. She's leading, developing, and managing research and related projects on the population health issues in the Middle East and North Africa, MENA region. She had published more than 50 research articles internationally. She also supports IPH's population health education and community awareness in Qatar. She is the course director of the Introduction to Systematic Review and Meta-Analysis, the Principles and Practice workshop. She also teaches biostatistics for healthcare professionals, mentors, Weill Cornell students, as well as research staff. Prior to joining IPH, she was a postdoc associate in healthcare policy and research at Weill Cornell. Her research focuses primarily on characterizing epidemiology of hepatitis C infections in the MENA region. She also has a master's in population health. In short, Dr. Maria here, I'm going to give on the podium to her. She's going to introduce to us some AI tools and how to leverage them in systematic reviews. Dr. Karima, welcome.
Assalamu alaikum. Thank you for the invitation. So today I'm going to talk about systematic reviews and how we can use AI. I will focus, as Ms. Maria said, on actually three specific steps of the systematic review. So first of all, I have nothing to disclose. And then here are the objectives of this talk. So we will explore how Raydan software can be used for screening and selecting articles when we are conducting a systematic review. And then we will describe how we can use Elicit. And then we will discuss how we can synthesize and report our work using generative AI. And then we will talk about the limitations. So first of all, here are the steps of conducting systematic reviews. So first of all, we frame a research question. Then we go on different databases. We search for the literature. Because we searched for on different databases, most likely we have duplicates. So we need to remove them and then go through a multi-stage screening, which is actually title abstract screening, then full text screening. When we have included our primary studies, the next step is data extraction. Then we do quality assessment, as Ms. Maria described, and then we go through synthesis. And the synthesis can include or not meta-analysis. So a systematic review, as Ms. Maria said in her talk, is very important. It synthesizes the evidence, helps to take evidence-based decision, but it has challenges. Here are some. It's a labor-intensive process. Actually, when we conduct a systematic review in our team, usually it takes at least 1 year to complete the systematic review. It takes time. It takes at least two individuals to do it, because when we do screening, the best way to do it is to do it by two reviewers. They will do it independently and then check together the discrepancies to minimize the errors. And it's the same process for data extraction and even for quality assessment, even if it's not mandatory by the guidelines. So it has a risk of human error, and you might know the publications are increasing year after year. So over the years, the volume of articles to be screened is huge. So we have resource limitations also. So AI, we have been talking about AI actually since 2005, and recently we have the integration of a large language model with generative AI, basically the Gemini, ChatGPT, Claude, DeepSeek. So what they claim? They claim to increase efficiency, enhance accuracy, reduce workload, and help us to do our work faster. But we will see that it can be an amazing tool, but it has a lot of limitations. So here are some tools. For research question development, you can use ChatGPT, DeepSeek, Search Refiner. For literature search, there are tools like Elicit, SciSpace. For screening, you have Raydan. Abstract, you have Covidence, which has an AI tool integrated in it. In data extraction, you can use Elicit, robot reviewers. Quality assessment, again, robot reviewers. And for synthesis, you can use ChatGPT, nested knowledge, and the other Gemini, Claude, DeepSeek, etc. So let's focus on Raydan. Raydan was developed here in Qatar at QCRI, and it's a very good tool because it's not focused on one type of systematic review, like, for example, Covidence. Covidence is a very nice, very good tool, but it's really adapted for systematic review of interventions. But Raydan is very open. You can use Raydan for any type of systematic review. This is why, for example, in my team, we are focusing on epidemiology, on population health topic mainly. So Raydan is very flexible. We can cover any topic. It will be a good tool. So I will not cover how to use Raydan. Basically, in our workshop, we spend 1.5 hours explaining how to use Raydan to our participants. But here, I will focus how to I will show you the AI component in Raydan. So Raydan is used to do the screening. Basically, if you Google it, this is the home page. And then, basically, when you have created your review, uploaded your included studies, you will see basically the list of included study here. And if you click on one, you will have the abstract. And you have here the title, the abstract, and publication types, the authors, etc. And then this tool helps you. You will read your abstract and decide if you want to include, exclude, and then you can discuss with your colleague who is doing it independently the final decision. So what is interesting in Raydan, basically, there are 2 steps to use the AI tool. First, from your pool of articles, you select randomly a sample of articles. And then with that sample, you will make a decision of including and excluding. By doing that, you are training the AI component of Raydan. You are training the AI tool on the decision patterns you are making, on what should be included and what should be excluded. Then after that, you can just click on a rating here, and then it will give you the decision that should be taken. So let me show you. So basically, here, when you have your list of included studies, if you click on sample, you will get this page. So you say that you are doing a sample on all the references. You want a randomized random sampling. You know that when we have a random sampling, the sample become representative of the whole pool of article. So, for example, from a 500 pool, an initial pool of 526 article, we can select 100 and make the decision. So the minimum number of decision to allow Raydan to give you the rating is 50, but obviously 50 is not enough. In normal systematic review, you have several thousand of articles to screen for title abstract, so you need to really screen many of them. For example, in our case, we take 30% of the initial look. So it's usually several hundred, around 1,000 articles to be screened, so you make sure that you are training properly the AI. Then you click on create, so then you have your pool, your sample. And then you start to decide to include and exclude here by clicking. You include, you exclude, you put the decision, the reason of exclusion. Then, when you are done with deciding for your sample, you click here, rating. So so then proceed. So Raydan will give you decisions. So you have double thumbs up, 1 thumbs up, a question mark, or thumbs down, double thumbs down, and one thumbs down. Okay. So before the rating was 5 stars. From 1 to 5, and 5 being 100% sure to be included, and 1 being a very low probability to be included, and then they changed it, and they are using thumbs up and thumbs down. So what we are doing is all the articles with double thumbs up are included. All the articles with double thumbs down are excluded. And then we manually still screen the one thumbs up and one thumbs down and the question mark. Question mark is the maybe. The tool doesn't know if it has to be included or not. Why? Because as we, the human, we, the researcher, are responsible of our research. So we don't, for the middle probability, we don't just go with the decision of the tool. We obviously check and make sure that that the decision is accurate. So it helps a lot. So it helps with a very big systematic review. When you want to include 10,000, for example, it will help to 10,000 articles. It will help reduce a lot the amount of article you are going to manually screen. Now for data extraction. Elicit is a good tool, I think, that can be used and can help the data extraction. So what I'm showing here is the free version. The free version will not allow you to extract all the included studies and all the variables, but it helps. So I would say that think about the AI tool as an assistant, as someone giving, not someone, as a tool that is giving you a piece of advice, but not doing the job on your behalf. So here again, you Google Elicit, you create your account, you enter, and then you create your extraction. So basically, you need to upload the PDF of the article you want to extract. And then here, for example, I uploaded this paper by Walid Kamal Abdel Basit. And here you have a predefined list of variables you can extract, or you can enter the variable you want specifically to extract. So for example, here, I ask Elicit to extract the intervention covered by this article, and also the comparator. You know, the PICOTS framework, it has population intervention comparator outcome and comparator outcome, and then you can have timing and setting. So these are at least the basic variables that you have to extract in any systematic review that is covering interventions. So here is how Elicit extracted. It extracted as a text. And if I'm going to show you now the actual paper. So you can see here the amount of text extracted for the intervention. And when you can see that actually there is more details related to the intervention in the actual article. So if you compare what was extracted here, it's correct, there is nothing wrong, but it's not complete. It's not complete. So it can be a good tool for you if you are hesitating about something when you are reading, if it's not clear. It can be also, if you have the paid version, then you can do multiple variables. It can give you a draft of an extraction sheet, but obviously you will need to read by yourself the article and complete the extraction. And also when you do analysis, like let's say you are doing extraction to do meta-analysis, obviously this is not the way how we extract to conduct analysis, biostatistical analysis. There are different ways, like to do an analysis. We don't write paragraphs. Each variable need to be in a separate column, and you put one number in a separate column, etc. I mean, I will not explain how to do data extraction. It's also an hour and a half in our workshop. So I'm just giving you an example of extraction. So it's not complete, and it's not adapted for statistical analysis. So it can be used as a draft, as an assistant, but not doing the job for you. So now synthesis. So a crucial step when we are writing a systematic review is the synthesis. We have done all the job, data extraction, looked at the data, read the papers, and now we need to synthesize. The synthesis, so there are two parts in the synthesis. There is the writing itself, the reporting itself. So tools like ChatGPT, Claude, DeepSeek, Gemini are very helpful in helping you writing. So you have something in mind, you don't know really how to write it. A lot of us, English is not the first language, it's not our mother tongue. So it helps, it's a good, very good help. It can rephrase, it can help you make it more concise. So it's a very, very nice tool for writing. Now, it has limitation. If you are giving a table to ChatGPT, for example, and ask ChatGPT to write for you the results section, you really need to be understanding what is in the table to check if ChatGPT did a mistake or not, because it hallucinates and it can miss some stuff in the way how it should have been written. If you give an odd ratio, one odd ratio to ChatGPT and ask to write a sentence, it will do it most often correctly, but if you give a whole table, it will be more complicated. It can miss things. So you need to be, it's really like an assistant. You need really to check to make sure that there is no error, nothing missed, nothing added. And there are tips to avoid what we call hallucination. Hallucination is basically when it's giving you an answer and you don't know from where it is coming. It just like brings something completely wrong, completely from nowhere. So you can, like when you are writing the prompt, say, I don't know if you don't know, for example. You add it at the end of your prompt, so you don't get something just because the tool thinks that it has to give an answer. For example, I give you an example. Once I asked ChatGPT to find for me a citation. I gave a statement. I was writing an intro. I wrote a statement, and I was like, okay, I have to find a citation for that. I asked the citation. I asked ChatGPT to find the citation, and it gave me a very nice citation, the journal, like a nice title, journal, etc. And obviously, I know that I have to check every time. And I was looking for that article, and it was not there. It doesn't exist. And I thought, that article doesn't exist. Oh, sorry, I didn't know that I have to give you a reference of an existing citation. So be very, very careful. It's an amazing tool, I agree, but you need to check everything. So then also you can, it becomes your work. You can't ask ChatGPT to write a paragraph for you and you just copy-paste it. This is, I mean, you give then the copyright to ChatGPT. But if you are writing, rephrasing, checking, making sure that it's accurate, it's factual, it's evidence-based, and the sentence doesn't have sometimes it will state something, but it's not completely accurate. Then it becomes really your work. You have worked on that paragraph. You have rephrased it so many times. So it's yours, okay? So the limitation, I have talked a lot. Human expertise is a must. You have to double check everything. You need to believe in yourself and believe in your expertise. It's not because ChatGPT said it, it means that it's true. Yeah, that's it.
Thank you very much, Dr. Karima. You can have a seat on the podium. Any questions from the audience? So, Maria, I have a question. Risk of bias is very subjective. What did you need to do to feed into the AI tool to make it less subjective, more objective, so it stays with the track? And what were your challenges when you ran?
Thank you, Dr. Noora. So basically, prompts are very important when you're using Gemini and ChatGPT. As Dr. Hassan Kurban told me earlier, there's no logic behind the formatting of ChatGPT and Gemini as OpenAI programs. So it's very important that you put your prompt as specific as possible. And like what Dr. Karima has said in her presentation, if you have to, I have to also put prompts like, if you don't know, say you don't know. Make sure that the article actually exists. Give me the proper DOI and citation format. Or I could also say, please list down the format in APA format. Challenges would definitely be AI hallucination. With ChatGPT and Gemini 5 out of 10 times, I have encountered that the article that was cited to me was not actually published. So I had to do a lot of rechecking and revalidation. So sometimes I had done 20 articles in, and I find that 5 out of 20 is actually non-existing at all.
And to confirm, the Gemini you used was a paid version?
Yes, it was paid version, yeah.
Any other questions? Dr. Karima, you're from Weill Cornell, and a lot of the AI tools give you a taste of the power they have, but never the full access, full power until you pay. We're always looking for affiliations and institutional access. Does Cornell have any institutional kind of access, maybe for any of the tools like Covidence, Raydan, any of these tools?
So for Raydan, it's per department, like the per department pay the subscription, basically, for the professional version. But actually, I just wanted to comment that for Raydan, actually, even the unpaid version is very, very efficient. We have access to Copilot as available by the institution. Yeah. So basically, in general, is per department or individual initiative.
And do you yourself think that you would one day maybe give away one of the steps, I'm talking completely, for AI to do it for you? Risk of bias assessment, for example?
Not at all. No, I really think for any kind of task we are asking AI to do, we really need to check everything. I don't think AI is going to replace any, maybe not, I wouldn't say in a general way, but it's more like people using AI will replace the people who don't use AI, but I don't think AI will replace a human, because we always need to check. We know always, because there are these hallucinations, there are, you know, there is always the human touch that is needed to put nuances, to make sure that this is the right thing to do. So I don't think AI will replace, for now at least, any. Always we have the last word that needs to be done. The decision has to be done by the human, including, non-including a study has to be done at the end by the human who is taking responsibility of this research, is the author. Or I mean, as a healthcare professional, if you are taking a decision at the end, you are responsible. So even if you are using an AI tool to help you for the diagnostic, at the end it's your decision, and it has to be like evidence-based. You need to be knowledgeable. You need to have some expertise to be able to make sure that AI is not is not biased, is not making a hallucination, etc.
One of the things that delay usually the release of a systematic review is that it's dragging too long, because it's take too long to get to an agreement. A lot of the steps in the systematic review are done in duplicates. So if you can't completely take away the human factor, can you take away the duplicate, have bot and human together working on a systematic review as opposed to 2 or 3 humans doing the systematic review? Is that something that you think is more realistic?
There is no guideline so far recommending that, but we have been discussing, because it takes so much like time and human resources. So like asking LEC to do the extraction and then another person come and check and add whatever it's missing could be a good way of reducing the time. And same for the screening. But for now, because when we conduct systematic review, we follow guidelines. So we have the PRISMA for reporting. We have, for example, AMSTAR2 for the quality, methodological quality. And for now, they are saying either 2 persons do the data extraction or screening independently, or one does it and the other check. They haven't added the AI component. So if you are saying, I have developed my systematic review as per PRISMA and AMSTAR2 guidelines, they are not saying it if you are using AI. For now, what we have been doing in our team is, we have been doing is, for example, for screening, we will train Raydan. We will look at what the decisions are provided, and but there will be always a second person checking all the excluded studies to make sure we are not missing anything. And then we will report in the paper that one person trained Raydan or the excluded study, because basically the purpose of a systematic review is to include all the available data. So what is the most important is to not exclude something that should have been included. So we always check what has been excluded. So, for example, one person will train the tool. A second person will check the excluded studies. We run the rating. We exclude the double thumbs down, and include the double thumbs down. But then there is that portion that needs to be done manually. So we need the second person to come and check what has been excluded again. So I think it helps. It still helps to save some time, but like counting on an AI tool like a full human, I don't think it's still, we need to be cautious.
Another way that I think it would be attractive to employ AI is keeping a live systematic review. So you've done the initial work, maybe during that you've trained your AI model and you want it to carry out the same steps that you've done, maybe with a human person to check. Do you think that is also a feasible thing? Do you know of any ongoing work utilizing the same methodology?
I don't, but I think as long as we have a human checking, it should be like a good strategy, and we should start trying and comparing the two methodology without and with AI, and continuing publishing to make people more confident and more comfortable to use the AI tool. Yeah.
Assalamu alaikum. Really interesting talks. The problem with AI is it advances so quickly and so rapidly. The search engines are getting faster, smarter, and stronger. Now, the so-called hallucinations, or I call it fake news. Yeah. So if you're trained and you're doing a lot of manual work to sift out the fake papers, is there an AI to ask which of these AI engines is fake news?
You can ask ChatGPT, for example, what are the tools, the AI tools to do whatever step. I just want to make a comment. We know that all the tools are trained, yes. And we know that those are trained on databases. Those databases can be biased or not adapted. For example, if you train a tool that makes diagnostic and it's trained in the US, maybe it's not adaptable here because the population is not the same, even if they have been ethnically diverse there, because the environment is not the same. Maybe it's not adaptable here. There is this kind, we are aware, and I think more and more people who are using AI are aware that the database for the training can be problematic, for example, and we need to pay attention to that. But also, if you take ChatGPT and DeepSeek, for example, if you ask DeepSeek about Taiwan, you will get the answer as per what the Chinese government wants. And if you ask ChatGPT about Gaza and Israel, you will have what Western country want us to believe. So even the algorithm itself can be biased.
That's right.
So this is why I always say you need the human perspective, because what you believe is right and you think is the right decision might not be the right decision in another part of the world, you know. So this is why I always say, like, we need a human, and then you can use all those tools, but always with critical thinking.
Now to introduce our keynote speaker, please welcome our moderator, Vice Chair of Surgery and Division Chief of Plastic and Craniofacial Surgery, Dr. Mitchell, Scotland. Thank you.
And I just want to give a quick plug to this meeting, which is coming up in 61 days and I think 18 hours now. This is the second Artificial Intelligence and Medicine meeting that we're holding here in Sidra, and it's going to be fantastic. We have an all-day workshop on the 23rd, and then we'll have about 50 presentations from speakers from really around the world. We have speakers, I think, coming from about 14, 15 different countries, really leading authorities. There'll be about 50 presentations, 3 panels, a panel each day, and I hope some of you will be able to join us. It's going to be a great show. So I'm going to hand over to Dr. Hassan Kurban now.
Can you hear me? Assalamu alaikum, marhaba. Good afternoon, everyone. Oh, it's all about AI, right? So, what I'm gonna do, first of all, it is an honor to be here in front of you to discuss the topic that will define the next decade of medicine, right? Especially in the clinical settings. So the point I'm making, imagine a future where AI is diagnosis, making very accurate, faster diagnosis for many diseases, better than any human doctor, right? Human doctor. I'm not threatening your job, just letting you know. You'll be fine, I'm on your side. Let's make it clear. But imagine another feature where AI is making misdiagnosis, right? Or in other words, making wrong treatment recommendation or missing life-threatening cases. Which one would you prefer? I hope everyone will prefer one. I hope you are not worried about your job, right? So this is not a theoretical question. It's already happening, right? AI is making groundbreaking advancements in medicine, yet it is facing significant challenges, some of which led to critical failures in clinical settings already. Let me pick my clicker. I like interaction. Since I teach a lot, right? We like to talk and interact. Okay, let me go back actually. Today, I will take you through 3 important steps. First, please do not judge me. I will make sure everyone understands what AI is. Considering my experience, mostly AI is misunderstood. So I will simplify AI, then we will briefly discuss why it is all about AI. Then in the second stage, I will provide a structured framework that can be used in medicine or any domain to do AI properly or build successful AI application or do good AI innovation, successful AI innovation. In the third part, we will go through 2 case studies to make sure we understand this structure framework. This is the plan for today. Long story short, by the end of this talk, my goal is to help you understand a clear roadmap to build successful AI innovation in medicine, what it means, clinically useful, right? Ethically sound, and also practically viable. This is my goal for today's keynote. So we will start with AI. What is AI? So I try to visualize public AI understanding. And sorry, my skills are not good. I was able to come up with this image. So currently in industry, even in academia, please do not judge me, AI is seen as a magic box. You throw a piece of data or something to the box, and it can return anything you want, which is totally wrong, which is totally wrong. Then the next question is, what is AI, right? If AI is not a magic box, what is AI? So basically, you cannot throw a piece of data to the magic box, which is AI, and produce you a doctor. So don't worry about your job. I told you, I'm on your side. Sorry. To be able to understand what AI is, we need to check where it is used. It is used in computers, right? Then what is computer? Computer is a search machine designed for search purposes. Then what is search, right? Search means in real life, whenever we have a challenging problem, basically there are a lot of too many options, billions of, and we cannot find the answer. What we usually do, we take that problem and represent it for the device we designed and call computer, okay, and run the search more efficiently. AI is one of the tools we use for the same purpose. AI is simply an optimization algorithm which is used for search. It cannot design you anything you want. Let's first simplify it. So now the next question, how AI is doing the search? Similar to the computer, the same story. Let's give an example on the application you love the most, which is large language models, right? Maybe I should name a company you love the most, probably ChatGPT, right? Probably you love more than anyone you know in your life. So, same story. The problem is taken from the real world, redesigned so that we can do the search in computers. That's all. Let me explain how it works. What is the search we want to do? We want to search over the text, right? Information. So what we do, we represent the text, all the text, books, web pages, whatever text exists out there as digital data, represented as a network. Basically, we call them, vector representation. What it does, basically, in this network, we encode an autoregressive model. What it means is the model knows what is the most likely word from after each word that exists in English. In the first model, 50,000 words in English were considered. So, as I promised, we took the problem, represented for computers, we can do the search, right? First, we need to represent it because computers are binary machines. They work based on propositional logic. Everything only can be ran binary. So this is what AI is. It's a simply good, maybe the most advanced search technique we have, especially for difficult search problems. So let's simplify it. Okay, then why it matters? Why, if AI is simple, why everyone is talking about AI, right? Let's try to understand that. This slide explains everything. The ratio of debt to total GDP right now is more than 100%. That means we consume more than we produce. So we need productivity. That's the only promising tool nowadays we have for hope. It is estimated that AI will contribute around $15 trillion to the total GDP by 2030. And when you consider the current total GDP, which is a little bit over $100 trillion, it's a big productivity. Can AI achieve this? I'm not going to answer that question, just letting you know. So a little bit history. From 1940 to 2020s is the entire AI history, formal. And you see all the theories, important theories, for example, transformers. With transformers, we were able to design the large language models like ChatGPT. You see some important personalities for AI community. And what is important in this slide is the top part, which are labeled third, golden ages and dark ages. So golden age means a lot of hypes about AI. So in industry, in academia, everywhere, wherever you go, everyone talks about AI. So we are going through actually one of them, right? It's all about AI nowadays. And as you see, this is the third golden age. And we have had so far 2 dark ages. It means hype is gone, everyone is pessimistic about AI. They understand it's just search algorithm, cannot solve all the problems. So the next question you need to answer right now, what is next? We are already having the longest golden age in AI history. Will it continue, or are we very close to the end? And we will start maybe a new dark age. We don't know. So you need to decide it on your own. Because I'm biased, right? Okay, your opinion matters. So can you please scan the code and share your opinion with us? So you'll get a question over there. So that doesn't work. Yeah, you made me confused. I was like, what is she? He's, okay. So do you find using AI trustworthy in medicine? We are not collecting your data, don't worry. So I promise. It's not opening? It's opening? It's opening. Probably Wi-Fi problem. Okay, let's see. I will share the results here. I have it on my screen, but you cannot see it, sorry. So that's for next question. So, okay, let me share the results so far. Because of the technical issues, I have the result on my personal computers. So neutral is, most of you voted for neutral or somewhat trusted. And only 3 people completely distrust it. So it's interesting. So it looks like most of us are confused about AI, the potential of AI. So, the most important part of the talk, the framework to build successful AI application or build successful AI companies in any domain, but our focus will be medicine. So I will cover 9 key factors we always consider while working on real-world AI application. Briefly, the first one is the objective problem statement. The second one is the data. The third, infrastructure. Fourth, multidisciplinary team. The fifth, stakeholder buy-in. 6, clear return of investment metrics. And 7, ethics and compliance. 8, integration of new AI system to existing systems. And 9, continuous monitoring. So I will briefly explain each key factor. Let's start with clear objective. What does it mean? AI in medicine, any objective or the problem statement precisely and should be well-defined, precisely defined and well-defined. Avoiding broad and also ambiguous targets, goals. So everything must be very clear. Let me give you 2 examples. One for good AI objective, the other one is the bad one. If your goal in your AI objective is, let's say, somehow improve the diagnosis accuracy using AI, this is a very bad problem statement. Why? It's too broad. So we usually ask some main question: how? Using what kind of data? In what time frame? Etc. Let me give you another good one. Let's assume you are working on lung cancer, okay, detection of lung cancer. A good objective could be the following. We want to build an AI model that improves lung cancer detection in X-rays, I emphasize the data, by reducing the false positive 20%, not broad goals, okay, in, let's say, maybe 16 months. Everything must be mentioned in the objective. Why this is important? In this framework, problem statement is the most important factor. Why? The outcome of the AI project or the success of the AI project is measured as the function of the objective. So you need to make sure it is not broad and nothing is unambiguous. So the data. AI in medicine is only as good as the data that learns from. Biased data, inaccurate data, or incomplete data will create a lot of issues, right? For example, misdiagnosis, right? Missing life-threatening cases. So data accuracy very important. In this framework, this part is the most time-consuming factor in our framework. So you need to be aware that it may take for a long time to collect the data you need and process it. It's very expensive. It is the most expensive part of the framework in terms of time, in some cases also in terms of the cost. So AI is not free, right? You are surprised maybe. It comes with a lot of costs. Without the right infrastructure, AI in medicine cannot function effectively. It requires high performance computing, secure databases, and also real-time processing capabilities. It comes with a lot of cost. So most of the companies you know, including all the large language companies, they are still losing money. These tools are not cheap to build and maintain, just letting you know. So the fourth one is the multidisciplinary team. You cannot hire an AI expert to solve an AI problem. You will need a multidisciplinary team. If you are interested in building AI application which will be ethically sound, right? That's the first thing we want. Or practically viable, you need a multidisciplinary team. How we do it usually, or what you need in medicine when you work on AI application. What kind of team you need? Of course, you need computational scientists or computer scientists or computer engineer like AI engineers, AI scientists, data scientists, software engineer. And of course, you need the domain experts, the medical experts like doctors, nurses. They must be included in the team. That's not enough. You need some policy experts, plus hospital ITs in the team, and also hospital administrators. So it's a very comprehensive team. And as you see, it is not cheap to put all these people together. So the fifth one, stakeholder buy-in. What it means, and let me start with this. Believe it or not, most of the AI projects fail because of this. So whenever you work on an AI project, when you put people together from different disciplines, you need everyone's support. If there are people in the team, they don't believe in the AI, okay, it's very likely that project will fail. Let me give you an example. Let's assume the nurse in the team doesn't believe in AI. You can solve the issue using the AI, but if the nurse doesn't want to use it, what will happen? The project will become a trash, basically. No one will use it. So this is very sensitive. Okay, clear return of investment. Every medical institution, before getting into AI project, they should have a clear return of investment. Let me give you an example. Let's assume in our hospital, in Sidra, radiologists, okay, they have high workload, let's assume. And also, we want to reduce to MRI or CT scan turnout times, okay? What we can do is, and we want to do it with AI. That's the optimization or search problem we want to work on. So we can build an AI assistant, right? That will basically make some prediction for reviewer to basically to reduce the time. Maybe the ROI of the hospital could be the following, right? Reduce to maybe prediction time by, let's say, 40%. With less mistakes, right? Misdiagnosis, maybe 30%. And save maybe $1 million per year. Very straightforward return of investment plan. So you know what you are going to get. So if there is no return of investment plan, since AI projects, successful AI project takes a lot of time, what will happen? The support will go away for the project. And it is very likely it will fail. So ethics and compliance. AI in medicine must be private, fair, transparent, and must comply with all policies. So privacy here means data protection, patients' data protection. There are a lot of protocols for that. We need to make sure the patient's data is securely stored. Fair means the AI model will work equally across all demographics. Let me give you an example. Maybe you train an AI model, okay, for a specific ethnicity, it makes a lot of mistakes. And you went back, collected more data, and make your data more diverse and fix the issue, right? So this matters, especially in medicine. Transparency means we need to make sure doctors trust AI, okay, and understand the prediction of AI. So it must be interpretable. And lastly, of course, we need to go with medical policies, right? Like similar to FDA clearance, etc. Okay, another question, the one I'm most excited about. Let's see what you are going to get. Let me change the question quickly. You should be able to see it now, I think. Who is responsible when an AI makes a wrong medical decision? So the AI company, the hospital, or the doctor? Of course, the hospital, right? Oh, doctor, mostly? Or the AI company? No, I don't want to be responsible for anything. Okay, mostly doctor. Yeah, not the hospital. It's interesting. It looks like there are a lot of administrative people here, not the doctor. Okay, fair answer, fair answer. Okay, mostly the answer, 41 doctor and 28 the AI company. All participants must equally share the responsibility, everyone. This is my personal opinion, by the way. It's not a law. Okay, so integration. This is the most challenging one for medicine. Integrating the existing data systems with the new AI systems, it is the most challenging one for the future of medicine because of two reasons. The first one, a lot of regulations, a lot of clearance is required, which is time-consuming. The second one is the technical issues for integration of the software. which can be solved, but the first one is a big problem, a long-term big problem. Okay. Another misunderstanding part of AI is that you build the AI one time and it's over. Now you can go use it. No, there is no way you can do that. It doesn't matter what AI application you are building. You have to continuously monitor it and update it. Let me give you an example to explain this better. Imagine you build an AI for COVID-19 for some variants, okay? But now, in a year, there are new variants, and your AI model cannot understand. It will fail, right? What you need to do, you need to always improve the data and update your AI model regularly so it won't fail. That's another reason AI is very expensive. It requires continuous monitoring. Okay, so we went through 9 key factors. Now, let's practice this in 2 examples. So we will consider 2 case studies. One is a failed project. We will take IBM's Watson, well-known AI for oncology. The second one is a success story. We will take Behold.ai's red dot technology for early lung cancer detection. And we will try to understand why one failed and the other one was successful. So these are some historical pictures. In 2018, IBM Watson oncology AI was a big deal. So when you Google it on the web, you will see those pictures a lot. So this is basically the AI you see, the servers, the intelligent part, and the other one is the dashboard for the AI system. So the question IBM worked on that time, can we build an AI to generate cancer treatment plan for any type of cancer? That was the question. So they claim they built it. So it looks like they couldn't, and it failed. And we will now use our framework to understand why IBM Watson oncology AI software failed. So these are some recent studies about IBM's Watson's AI for oncology. So what they've done in different countries, okay, they try to use the AI software and the oncologists separately and check if the treatment plans for the cancers and different type of cancer, if they align or not with each other. So it turned out, as you see here, and we have different type of cancer here. Maybe for some of them, it might be a little bit better, but in reality, if the risk you are taking someone's life, right, even 1% is a big deal. So that's why, I mean, it failed after those experiments, and IBM decided to stop it. Now we will analyze this project through our framework. So first, you remember, well-defined objective. Their objective was too broad. They wanted to build AI doctor. What does AI doctor mean? Have you seen any doctor who can heal anyone for any problem? No, right? Just the objective is too broad. What they could have done, they will first target one type of cancer, right? Not even all of them. So the first main issue was the objective. It wasn't specific enough. And just too much expectations. You remember, the outcome of the AI project is measured as a function of the objective. If your objective is unrealistic, whatever you build, in business, it means you failed if it is not that good. That's why we always start with reasonable objectives. So second problem was the data quality. In their training data, they use biased doctor. It means some notes from each doctor for each cases to train their model. They added a lot of bias to the data. Of course, again, our expectation must be reasonable. And it should align with the real world. As I mentioned, there is no human doctor who can understand all medical issues, right? Why AI can do it? So lack of clear return of investment. Maybe the money wasn't the issue for IBM, right? But what went wrong for them, they weren't able to prove the medical institutions can be run more effectively using the software. No one wanted to use it. If there is no return, you cannot continue your business. So that's another thing they failed. And you should understand, real problems are very complex as a search problem. So if you can represent the problem knowledge very well, then AI will be more helpful. But representation of the domain or the knowledge is not easy. Just consider putting all cases for all cancer types together, right? That's not an easy task. So every part of the framework, one of the reasons you will fail because of the complexity. So in summary, the objective wasn't good enough, data wasn't good enough, the expectation wasn't realistic, the return of investment didn't work, and maybe they needed more domain experts, right? Okay, now the successful one. Let's go through the successful one. So in this problem, Behold.ai company, they wanted to do the early lung detection using AI. Look, just one type of cancer. And it's just prediction, early prediction. It is not as complex as what IBM wanted to do, right? They wanted to generate the plans, the cancer treatment plans, which is a harder task. It's a very simple, well-defined problem statement. Now we will go through our framework and understand why it was good enough to make it a successful AI project. So clear objective, compared to IBM, they consider only one type, and their goal was to reduce the time. So with AI, in real-world application, there is no way, again, I am just sharing my biased opinion with you, you can just use AI to solve the problem 100%. You will always need human in the loop. You can run AI as an optimization algorithm to get some feedback, then make the decision. For them, they didn't make the final decision. For them, let's reduce the time with AI and use it as an optimization algorithm. So this is the right way to use AI. So the objective was well defined with specific goals. So data, they use labeled 15,000 review, again, labeled radiology images. They verified the data. So the data was good enough to do this. Remember, the application, AI application you are going to build will be only as good as the data that learns from. So they had the good data with a clear objective. Yeah, they build a good team. A lot of AI experts with the domain expert. So perfect team. And for the return of investment metric, their goal, again, reduce the processing time. So they were able to do it under 30 seconds. That was one of their ROI for the project. And with more than 95% accuracy. Still, look, it's not 100%. So they got FDA clearance for this. So perfect ethics and also compliance project. And continuous monitoring, they've been continuously monitor this project. If there are new cases they need to consider in data, they've been improving the data they have and updating their model accordingly. So in summary, Behold AI had a clear objective, good enough data, good team for the project, good return of investment, and they've been handling the project properly. It means continuous monitoring. Okay, the last one, I promise. Your opinion matters. And we are not storing your data, don't worry. So you should have it now. Which area of healthcare could be benefit the most from AI? There are some options on the top like surgery, diagnostics, patient monitoring, treatment, planning, drug development, or you can pick your own field. Okay, let's see the answers. Okay, most of you are now patient monitoring, diagnostics. Let me see. I got some surgery. It is, which area of healthcare could benefit the most from AI? Which one? Surgery?
If I could answer.
Look, he's going with surgery. That would be also my last option. I would pick it as the last, the surgery. I agree with her. Okay, so it looks like mostly patient monitoring and diagnostic. So no one believes in AI, or you guys find AI not trustworthy, it looks like.
I named radiology as well, obviously.
Yeah, it already works. And I think the highest one is out of 77 votes, patient monitoring, just letting you know. Okay, the conclusion, what we have learned today. The first thing I would like to re-emphasize, AI is not a magic box. Be careful when you use it. It's a simple, the most advanced search technique we use in computer to solve very complex search problems. That's the first thing. The second thing, building successful AI application is so challenging. Most of the AI startups fail. Maybe, I don't know, more than at least 80%. This is a very useful tool, but it is not easy to use. Make sure you're aware of this. You cannot just put some data together and build a successful AI application. It doesn't work like that. So, another important thing, continuous monitoring. You can train an AI model. So I usually interact with people in academia and in business a lot, and even government. Most people believe when they put some data together and use some algorithm to train it, they will solve a problem. They will make money out of this or help other people. It doesn't work like that. It requires continuous monitoring. And AI, one more time, it is expensive. It comes with some price, and that price is a big number. Imagine ChatGPT is still losing money, a lot of money, every day. So thank you for your attention. I will stop here.
Thank you, Dr. Hassan. And I apologize, I was not given the formal introduction for you. I wasn't given the sheet before. I do know you beforehand. If you want to give me the formal introduction. It's after the fact, but he deserves it after that rousing talk. Dr. Hassan Korban is the director of the Korban Intelligence Lab, the assistant professor of College of Science and Engineering at Hamad bin Khalifa University, adjunct associate professor of computer science and data science at Indiana University, Bloomington, and an editor at Nature Scientific Reports, so that's good to know. Dr. Korban earned his PhD in computer science with a minor in statistics from Indiana University in Bloomington, USA in 2017. His research spans artificial intelligence, deep learning, software engineering, graph theory, and large-scale data analytics with applications in diverse fields, including computational material science, biology, sports analytics, education, public transportation, finance, and medicine. And I think lots of people here in Doha are trying to work with him, including some of us.
I appreciate their effort.
So I think we'll do questions after the next speaker, who is Tariq Abu Saqri. He's a senior architect at Sidra Medicine in the Enterprise Architecture Services. Tariq has a Master's of Science in Data Science and AI from the University of Liverpool and a bachelor's degree in Management Information Systems from Al Zaytuna University of Jordan. Tariq has over 18 years of experience in data management and governance, AI and software applications, and cloud computing, and on-prem systems. He's led technical teams and managed large-scale data-driven initiatives. Tariq plays a crucial role in the data strategy, including its implementation, integration, security, governance, and architecture for both clinical and research data. So I think that's a good background for what he's going to talk about. I've seen his slides, and Tariq, over to you.
Thank you everybody for the opportunity to talk about the most important part these days is the AI. First thing, I apologize. I got the flu in the morning, so my sound will be not more clear. So my topic is about the AI and governance. I think we have covered a lot of important things on governance, but I will focus on how we go to the point directly, how to implement the solution through this governance and the technology and the processes of the AI. I have, first thing, I have nothing to disclose. You know, this is the learning objectives, and most of them applicable on the AI governance topic. But the important part, how we will implement this, how we utilize and implemented this in Sidra with use cases. So AI governance in healthcare is crucial for ensuring AI systems are used responsibly, ethically, and effectively to improve patient care and clinical outcomes. This involves establishing framework and guidelines that addresses the unique challenges and opportunities presented by AI technology. When we talk about AI governance, we talk about three major elements. We talk about the governance framework and the technology, which will be used to host or to process the data or store the data, and the processes involved for the development, deployment, and the training of the AI models on the healthcare. So this should go through safe and ethical and efficient AI applications. It's addressed ethical concerns, bias, and explainability and accountability of the AI. Accountability maybe cover a lot of points about the accountability, but we will see how we implement it here in Sidra. And it addresses the technical challenges. We know AI always required high computational systems like a GPU graphical processing unit and different computational or high performance computational systems, which we will address in some. Governance is always a boring topic, so I will start with the technology and which technology we implemented here in Sidra, and to address the requirements and to address the AI implementation. Which is preferred because, you know, there is a regulation and compliance requirements to keep the data on-site Qatar data centers. So the most preferred data platform, AI platforms, is Azure Cloud Platform and Databricks. Our analytics team, led by Ahmed Abdel Latif, is implementing that part. And we have, there is another one missed here, is the high computational system, which is the HPC team led by Ahmed Al-Khouli and the infrastructure team to handle the AI requirements and application on Sidra on-premises systems. And the cloud platform, which is the GCP platform. GCP platform, we have implemented the Google Cloud platform with an integration manner with on-premises systems. It's like now it's one system where our data can flow securely between the different systems. Sorry, but I think this is the old version of the presentation, so missing some other topics. So. When we talk about the global infrastructure, we mean, I think, and Sidra on-premises system, we have done a work to set up them so the data can go through a secure manner through the systems. This integration will provide us with a scalability system and high performance system where we can run a high computational and a large scale data set. It has a lot of advanced AI and machine learning tools, pre-trained tools, so which can be utilized and implemented and help the team in the development and deployment of the AI systems on our support health care solution. The AI has a range of tools and advanced pre-trained models which can support the solutions on healthcare. It has a rich pre-trained models and systems which can be help our physician and clinician to deploy their AI solution. It facilitates the development and deployment of AI. How we did the setup, this is the technology setup. Yeah. We have did the integration setup between the on-premises systems and the Google Cloud. Google, how the data source from where it will be extracted from data source system like EHR system and imaging system. It goes through an encryption manner and data engineering and scientific preparation part. Here when I'm talking about the integration between the Google and Sidra on-premises, it seems like one platform. The data will be transferred securely between the systems where we can extract the data securely and push it to the cloud services through the secure tunnel. When it goes to the cloud, cloud has many services where we can host the data securely and utilize the AI platform. The AI platform which we deployed here is a Kubernetes cluster. Kubernetes cluster means containers for each AI case. So the AI is the cases. AI is the cases, and we need to make sure when we deploy the case, it is segregated from another case, and it should be on each container has case, so the container will be linked to the data source or the data, the AI data. The container is you can imagine it's the case, and the data is the case data. It will be linked to the AI platform. The Google Kubernetes has Vertex, they call it the Vertex AI, where we can help the clinician and the physician with minimal technical capability to deploy and train the AI model and on his data. So the processes is and the AI processes in healthcare it's not in healthcare. Any AI processes, it should contain these processes. Data preparation, it's how to prepare the data to collect a clean and ensure it's a high quality data, de-identify sensitive information, and perform quality checks to validate the data. This is the data preparation process. Data splitting, we need to split the data onto a training set and a test set, where typically we split it to 80 to 20%. Then we will start train the model and evaluate the model and deploy the model. Here, the tourism framework is the main governance. It's developed by the team here, IMT team, on IMT team by Salha, Paul, and other people. So tourism framework is a governance framework that ensure AI system solution components are trustworthy, resilient, and secure while aligned with ethical and legal and business objectives. It ensure AI system trustworthy, resilient, and secure. Ensure that AI projects are aligned with ethical, legal, and business objectives too. Ensure responsible AI. When we talk about the tourism, it's trust, risk, and security management. Trust is ensure explainability, transparency, and fairness in AI model. Explainability, AI decision must be interrupted by both technical and non-technical users. This helps understand how AI model make decisions and ensure accountability. And transparency, AI capability and limitations should be openly communicated. This builds trust and security and trust with the stakeholders by providing clear insight into operation. Fairness, monitor and mitigate bias in data and models, ensure fairness in AI systems, help in preventing and promoting equality. And the risk, we have to identify and evaluate the risk associated. We do stress testing of AI models. Risk mitigation, develop standard operation procedures for managing failures or unintended consequences. This ensures that there are clear guidelines for addressing issues when they arise. Also, management and compliance. We should make sure that the system are compliant with legal and regulatory standards. This ensures AI projects adhere to relevant law and guidelines. Quickly go through the cases. First case, we used to deploy AI model to de-identify the clinical notes using the BERT. BERT is the natural language processing model. BERT is developed by Google. It's used to process the NLP task, natural language processing task. Then Facebook came to the picture and developed this BERT by making it more for general text, for general language understanding tasks. Then the Harvard team, the Harvard Health Science and Technology team came to develop the clinical BERT. Clinical BERT is a natural language processing for the clinical and medical context. It can used for the clinical text classification and the disease prediction, adverse drug detection and reaction and detection. So the clinical BERT, it can be used for analyze the clinical notes. And we have some cases here. I will talk about the only cases related to the clinical side. So it's like a text classification, prediction of free admission, the patient. The clinical decision support system, it can be used to provide information to the physician and in the medical context manner, detecting and adverse the drug reactions. So here in Sidra, we used this model to analyze the clinical note and de-identify the note, so we can securely push the data to the Google platform where we can train and model and deploy the model in a secure manner and make sure the data, there is no any training model happen in a sensitive information. So this is a preferred architecture to not use the patient information through the research projects or studies. So this is, we will develop it or deploy it as a centralized service on Sidra to de-identify any data before it goes to the research platform. So they will make sure it's a securely study. It's the de-identification strategy. The process involved in the model is to anonymize and pseudonymization of the information. Anonymization means remove the patient information, PHI, and pseudonymization is to replace the PHI with a code or alternative name. In conclusion, we have deployed a technology infrastructure where we can deploy our AI cases, and we have run some cases, but the challenge, we need to go through the governance processes to make sure it's that safely deployment and trained on the data.
Thank you, Tariq. Before we open the floor to questions for a few minutes, I don't want to miss the opportunity to thank Dr. Mansour and Dr. Noora and Maria and the rest of the planning committee for SARD and all the presenters for bringing our department together in such a wonderful, stimulating day. Really, it's incredible. It keeps getting better every year, like I said to you, and thank you so much. Really, it's great. Any questions from the floor?
Yeah, to de-identify the clinical note. Yes, it can serve the research project and the clinical service projects. But this implementation is for research project, is to de-identify the clinical note so we can do medical coding and help the medical coders in the process of coding. So then we need to push this data to the AI system, so it should be pushed securely before. And you know, the clinical notes contain many sensitive information, which should be de-identified before it.
I wanted to ask Dr. Mansour, go ahead.
Yeah. First of all, I would like to thank both of our guests for the wonderful presentation. There is no doubt AI, it has a huge role in healthcare in general. I think about it as two different pathways if you wanted to have a direct patient or indirectly related to the patient. For example, informatics and all these aiding tools for the doctors, such as transcription, even diagnostic reading and thing. And then there is the dangerous part, which is very, very scary. In the same time, will be very useful for surgeons. For example, how much an automated tool can be put on a patient and perform a procedure, for example. So can you elaborate on that?
So first of all, I mentioned in my talk, I'm on your side. I don't believe AI will replace the doctors. So I'm on your side. And of course, I have valid arguments, so we don't need to discuss it here. But for your question, for surgeries, yes, it can be used for precision purposes. I completely agree. But one thing we need to keep in mind, AI is only good to capture the patterns. It is not context aware. It means it is not intelligent. It cannot reason. So when you consider all the medical related problems, yes, like image processing, as long as there are patterns similar to the text like we do for sentence generation, yes, AI will work. It's a search algorithm, you remember? But for reasoning, we don't know how to do it yet. Wherever there is a task where reasoning is required, I don't think that will be used at the moment. So the reason why we rely on computers, they work based on propositional logic. We know the input, we know the output. AI cannot do it. It's whatever AI system you build. Since it's a search algorithm, it will be an approximate solution. It is not like how we do it in computers, normally, through propositional logic. Propositional logic means reasoning. AI cannot reason. All the tools you have, none of them can reason. Even though they have the AI, they can reason, not theoretical reason, it is just good engineering. It's a better search algorithm. So for precision, yes, but for reasoning, no.
Yeah, one can argue, though, if you get an intuitive robot that does 1,000 prostatectomies in 1,000 hospitals, and you pool that data, now you have a robot that's seen 1 million prostatectomies. And that's more patterns than any single surgeon will ever see in their career. And the way we learn is by pattern recognition as well. So I could see a day where a robot has all this data of 1 million prostatectomies or 100 million prostatectomies, whatever, over a long enough period of time that will have way more experience than any surgeon. So I don't know. I wanted to ask a different question.
I would love to clarify. It's a fair question, and I would love to clarify. So I'm not going to get into any theoretical or philosophical discussion in terms of what intelligence is or what reasoning is. But the only thing I want to say, yeah. So I'm not getting into any philosophical discussion for intelligence, but reasoning means it's more than, from my perspective, capturing the patterns. So let's consider the example you gave. Yeah, maybe it will see more than 1,000, right? A lot of more experience, let's say, in summary. For all the cases, yes, maybe it can do better than human. But you don't even know if the knowledge is well represented. It means basically it is good enough. You know, there could be other cases, but for human can see other cases and make, you know, maybe better reasoning. Again, I use the term reasoning, but for machine, it is completely data-driven.
Obviously, it is a big question, and we can't answer in a 10-minute question and answer period. I want to ask a different philosophical question. So Dr. Karima, she made a comment before about the example of Taiwan, Gaza, and Israel, how the system is trained on, you know, different viewpoints and biases, and so you have to have a human there to correct the bias. But of course, that supposes that humans don't have bias. So whoever is there using the AI has a bias, and it may not be a better bias or less bias than the bias that was built into the training system. So I think it's a little bit, I won't say comical, but it's a little questionable to think that the user of the AI has less bias than the AI itself. And I'll give you another example. So we've done a little bit of work together. We built a system that tries to appraise faces. And how did we measure its performance? Well, we had humans measure the faces, and we call that ground truth, as if humans are the best arbiter of facial appraisal, but humans are biased. And so if you ask humans to look at children's faces and rate those faces on a scale, they might feel uncomfortable giving a child with a deformity a low scale because it feels bad to rate a child's face as being unattractive. And the machine actually is agnostic. The machine will just look at the structure and look at the range of normal and abnormal. So I think when we talk about bias,
Algorithmic bias, right?
there's the question of ground truth when you rely on humans supposes that humans don't have bias. And so we have to be very careful what we think is our ground truth.
I can have a comment here. AI always, when we run or apply a search, an AI algorithm, it is going to the data source. So which data source the AI will target? For example, in Gaza's case, when we prompt on the AI search, it's based on the prompting type. And what exactly you prompt? You targeted which database based on your prompting. We call it, for example, if the context of searching it's showing that you are interested in supporting Gaza, it will go to the data sources of supporting Gaza. The context of the search, is it to, I don't know, supporting the other part? So it will go to target a different data source. So it's not, there is a bias, yes, but also it's important how the roadmap of targeting the right data sources for the system.
I understand.
Yeah.
The user's bias too. So.
Yeah, the user bias. Yeah, user can utilize this and target a specific data source which is not intended for the objectives of the project or for the objectives of that information.
From my perspective, one last thing is it was.
No, should be red.
What? In the middle?
Should turn red.
So the problem with AI, we have unrealistic expectations. That's the issue. It's just it is simply a search algorithm. What I mean is Google search is also a search algorithm, right? It was better than a random search. It wasn't perfect, right? Google makes mistake when you do search. You don't even use it anymore. AI is the next step. We even with AI do little bit better search than Google does. It is always an approximation. Don't have high expectations from AI. There is no reasoning. Let me give you an example. Consider ChatGPT. Literally all text is taken from real world, represented digitally, and encoded as a network. It's literally, and in that network, what is represented is what is the most likely word from after each word. That's all. There is no reasoning. If you don't like any answer, when you ask those tools to regenerate it, it will generate you the second most likely, the third most likely. There is no reasoning.
May I ask the next question?
Yeah.
And this is switching gears to Tariq and then connecting what Dr. Hassan is doing. If I wanted to bring up an AI research project, how would I go about this? What are the next steps? Logistics now.
Yeah, I can help in this matter. So through our experience and knowledge on research, there is a data coming from the source system and it will go to the research environment. So this journey, it's very important journey, how to move the data there and make sure it's de-identified. Research should host non-sensitive information, and based on that, we can utilize the innovation or innovative models or pre-trained models or known models on this data safely. So to address that, as mentioned, we have deployed the Google one as an innovation platform for research purposes with computational resources, graphical computational resources, and integrated with the high performance systems, which is in Sidra. So we can deploy and run on large scale data set or a high computational data set like images and ultrasound images, like videos, which is required heavy computational resources which is not applicable or available here. So we address this on the Google services.
So simply put, let's say I'm looking at X-rays and the use of AI model to predict abnormalities in X-rays. From your side, from Sidra, de-identify, push to Google Cloud. Then
Yes.
from Google Cloud, take it to the AI
Yes.
model and train and then test.
Yes,
Is that
we
correct?
have several cases like this, Dr. Tariq Abbas, and we have also Dr. Muhammad Al-Miski, where we leukemia images. Dr. Tariq Abbas has ultrasound for kidney, where we de-identified these images and pushed to the Google services, where he trained and ran the model on that and the research environment. So safely, he was not aware of to implement additional security to protect the privacy. So all the data is maintained and de-identified locally, then pushed to that environment.
Just a really quick follow-up. So I built an app, and it's being used through Google GCP.
Okay.
But we paid out of our grant. So are you saying that Sidra actually will provide us, for research purposes, access to the cloud for free?
Oh, yes.
I wish I knew that. So that wraps up this session. I'm going to thank you so much to both Dr. Hassan and Dr. Tariq. So that wraps up this session. I'm going to thank you so much to both Dr. Hassan and Dr. Tariq.
All right. Thank you, everyone, to our last speakers and panel, and thank you for the discussion, the audience. We're now coming to our last and most important segment of the session today. We are going to speak about our award ceremony, awarding our winners from the competitions. This year, we've named our award after the late Dr. Michael Levis. His wife, Pauline Levis, is in the crowd today. So we're gonna give a good, nice, short few words that will not give enough credit to Mike and his great work. But I want to invite Dr. Tripti Sinha, pediatric anesthetist who's known Dr. Mike the longest, and to give a very short word.
Thank you, Noora, and thank you, the surgical department, I think, for this. It is with a heavy heart, but with also immense gratitude that I introduce to you my dear teacher, mentor, friend, and father-like figure, Dr. Michael David Levis, or Dr. Mike, as we fondly addressed him. Dr. Mike was born and raised in Vancouver, Canada. It is here that he completed his medical school before moving to Toronto for his training in anesthesia and critical care. He was an attending at this hospital for sick children, and this is where I met him in 2011 as a fellow. He would fondly remember the first day I met him as the day he had the worst laryngospasm in his career, obviously because of the mismanagement from his fellow. Now, despite that event, it was at that point of time that he was actually considering taking up coming to, as a pediatric anesthetist, coming to Doha at Hamad. He had an offer. And despite that event, he did take up the assignment to join Hamad Medical Corporation. Now, he arrived in Doha in February 2012 as the first qualified pediatric anesthetist in the state of Qatar. He then assembled a formidable team of pediatric anesthetists, first at Hamad, and then at Sidra, and it is because of his vision and efforts that we are now an integrated team of more than 25 pediatric anesthetists providing safe and quality care to the children in Qatar. Now, for all of you all who remember Mike as a highly skilled and learned pediatric anesthetist, it may come as a surprise to you that he started his career as an ED physician, and he was American board certified in emergency medicine. Mike was more than just a brilliant anesthetist. He was a healer, a mentor, and a source of unwavering compassion for all his young patients and their families. Every child who entered the OR under his care was met with not just medical expertise, but with kindness, reassurance, and a deep sense of safety. Beyond his clinical excellence, Dr. Mike was a teacher shaping the future of his specialty By sharing his wisdom with colleagues and trainees, he believed that knowledge was meant to be passed on and that every lesson learned had the power to save life. Apart from his exceptional clinical career, we remember him for his sharp intellect, positive spirit, his fine sense of humor, and exuberant laughter that echoed across the halls. He had taste for many fine things in life, especially music. He supported a music fellowship in Canada, and he was a mighty good singer himself. We were a few who had the chance to hear him. On May 22nd last year, he left us after a hard-fought battle with cancer. He will be deeply missed, but his legacy lives in every child he cared for, every student he inspired, and every life he touched. It is only fitting that we have established this award in Dr. Mike's honor, a tribute to his passion, his commitment, and his contribution as the pioneer in the field of pediatric anesthesia in the state of Qatar. We are grateful to his wife, Pauline, who joins us today for the inaugural award ceremony given to those who embody the same excellence and dedication in the field of quality and research that defined his career. Thank you very much.
So I would like now to welcome to the stage Dr. Mansour and Pauline, and then present the awards to the winners from both research category and the quality category. So from the research category, the winner is Dr. Badar from pulmonology on his presentation on eventration management and congratulations. And for the winner, for the quality segment for this year is going to be Dr. Yaser El Hout for his model for catheterization. Thank you, everyone. I'd like to invite.
Yeah, just before we finish, thank you, Pauline, again. It's really pleasure having you here. And by the way, she just flew in this morning to be with us. So thank you very much. You can sit down. Yeah, we'll take a photo now. Just at the end, I just want to thank everybody. Of course, Dr. Noora and my teams. Where is Noor? Noor, Maria, everybody was involved, you know. You guys done a great job. Every year you just push the limit to a higher level for the next year. I wish you a really nice weekend. We would love to have you all for a group photo. Thank you very much again.